இல்லையா? ஸ்டூடியோக்குள்ள போட்டோ எடுப்போம். லைட்டிங் குத்துவிளக்கு, தண்ணி வேண்டியது, அதான் உனக்கு வைக்கலாம். இது first. இப்ப நீங்க எடுத்துட்டு வந்தது இப்ப முதல்ல வந்து, இனாகுரேஷன் டயத்துல சென்ட்ரல் செட் பண்ணி ஃபாலோ பண்ணுங்க. இல்ல இது இன்னும் ஹலோ செக் செக். ஒரு 1 மினிட் டிலே ஆகும். எல்லா யூடியூப்லயுமே இந்த சவுண்ட் வருதுங்களா? இல்ல இந்த சவுண்ட் வரல. இந்த சவுண்ட் வரல. ப்ளே பண்ணிடணும். இவ்வளோ எவ்வளோ நேரம் ப்ளே பண்ணுறது? பிஜிஎம் மைக் வந்து ஆன்ல தானே இருக்கு. பாஸ் ஆயிடுச்சு வருது. இந்த மைக் சொல்லுங்களா? இவ்வளோ செக் செக் ஆ செக் செக் வந்துச்சா? ஒரு நிமிஷம் இதாக பண்ணிக்கலாம். ஆ ஓகேக்கா. லேப்ல வரும். ஓ அது இது அவங்க பேசுறாங்க. கெஸ்ட் பஸ். இல்ல கெஸ்ட் உங்க மைக்ல பேசுறாங்க. இந்த மைக் வரும். இல்ல இல்ல ஆமா. கண்டிப்பா. சாப்பிட்டு வைங்க வந்து செக் செக் 1 2 3 செக் ஹலோ செக் வருதான்னு பாருங்க. வருதுங்களா? ம். நீங்க அந்த ஒயிட் கலர் மைக்கு இது ஒர்க் ஆகுது. சின்ன ஸ்பீக்கரா? இதுவா? ம் இதுதான் சரி. இது மட்டும் தான் ஒர்க் பண்ணுவீங்களா? இதுவும் ஆ, ரெண்டு இடத்துக்குமே ஒரு மைக் போதும். ரெண்டு இடத்துக்குமே ஒண்ணு ஒண்ணு போதும். அங்க வந்து இந்த மைக் பார்ப்போம். எந்த மைக்கா? போடியம் மைக் இருக்குல்ல? போடியம் மிக்சர் போவாங்க. ஸ்பீக்கர் தான் சைட் செட் பண்ணோம். ஸ்டாண்ட் மாதிரி வச்சு ஸ்டாண்ட் மாதிரி வச்சீங்கன்னா ஆடியோ மேல ஸ்பீக்கர்ஸ் இருந்தா இது வருதா? செக் செக் வருதா? பாட்டு வருதா? இது No puede ser eso. ¿Qué te valió? Bueno, ok. Sound check பண்ணிக்கோ. Check, check, 1, 2, 3. Hello, check. Start பண்ணு. ஒரு இருக்கு நான். ஆ, ஓகே. Check, 1, 2. That's it. Check 1, 2, 3. Hello. Welcome to Angel. Check, check. 1, 2, 3. Check. இல்ல, இல்ல. நான் செக் பண்ணிட்டு வரேன். எல்லா லைவ்லயும் இப்படிதான் check. Hello, hello. Check. 1, 2, 3. Welcome to MGM. Check 1 2 3 check. She's hosting that. Very good morning. Warm welcome. Greetings from MGM Healthcare. Welcome everyone for this EBUS CME for the commemoration of World Lung Day. So we have a lot of activities to start with the CME program. CME talk on 3 EBUS session, followed by we have inauguration session and the keynote session and the lunch. Post lunch we have a panel discussion and the workstation. EBUS, all about the EBUS. And in between we have a keynote session on TB and sleep apnea and lung cancer diagnosis, everything. I request everyone now, stay tuned. There is a few housekeeping announcement. I request everyone, keep the mobile phone on your silent mode. And we have a tea break after the inauguration. So this is a brief about thing. So welcome all the stalwarts and PGs, everything for this program. I hand over the mic to Deepika for the announcement and the other for the students for the scientific sessions. Dr. Deepika is our consultant transplant pulmonologist. He is well versed in all EBUS program along with Dr. Samitra Sinha. Over to Dr. Deepika.
Thank you, sir. A very good morning, a very warm welcome to all our eminent faculty and delegates over here. It gives me great pleasure in seeing such large numbers on a Sunday morning. When myself and Jairam sir was brainstorming about this CME program, we were stressing about a particular thing that we wanted to keep it as clinical as possible. So hope all of you have a great time, gather a lot of clinical acumen from all the speakers and chairpersons. To spice things up a bit, we have rapid fire quiz sessions in between the sessions for faculty separately and for postgraduates with cash prizes. So do participate in it. And to cut short like the delays in between sessions, we request you guys to note down your questions that you want to direct towards the speakers and hand it over to our postgraduates who will be standing across the aisle. We will direct them to the speakers so that by then we'll cut short the delays. So let's jump to our first session. I welcome our chairpersons for the first session, Dr. A.R. Gayatri ma'am, consultant at Apollo Healthcare. Dr. Supraja ma'am, consultant and head at Medway Hospitals. Dr. Tilagavati ma'am, consultant and head at Vijaya Health Center. Our first speaker for the day needs no introduction. He's someone who's very, very energetic and very, very eminent in this field. I would like to coin him as if ChatGPT had like a face in a person, it would be this person. You give him anything and he'll probably have an answer to it. I welcome Dr. Yuvarajan sir, consultant at Sri Manakula Vinayaka Hospitals, Pondicherry.
First of all, thanks for the nice introduction.
Good morning, everyone. Welcome to today's first session of the CME at MGM Hospitals on commemoration of World Lung Day. We have a dynamic speaker from Pondicherry, Dr. S. Yuvarajan, from the professor and head of department of Manakula Vinayaka Medical College. He's a faculty in various national and international conferences, well published, a very good area, a clinician, academician. And without further ado, invite Dr. Yuvarajan to give his talk on lymph node stations, how to do it, what to see. And we look forward to a very enterprising talk from you, Dr. Yuvarajan.
First, we welcome our Professor Raghunandan sir, today's CME observer from TNMC. Welcome, sir. I welcome all the professors, teachers, and postgraduate students and the consultants. Thank you. Over to Yuvarajan.
First of all, thanks for the nice invitation and introduction, and thanks to the chairperson for that nice words. First of all, I appreciate the effort taken by Dr. Jairam sir and team for this CME. And the topic that is given to me is the basic one for the EBUS sampling, that is lymph node stations. As you all know, this lymph node station is the basic thing. So if you want to excel in any interventions, I tell all the youngsters to get master in their basic knowledge or basic anatomy regarding the airway, regarding the lymph node station, all these things. Especially for EBUS, if you want to have good sampling uh, methods and good techniques, so you need to know the basics very well. So in the lymph node stations, I think just a recap. So we can classify the lymph node stations as superior mediastinal, aortic, inferior mediastinal, and highlight that nodes, N1 nodes. So basically, in superior mediastinal nodes, you see that it is numbered as 1 to 4. This superior mediastinal, the number one is highest mediastinal nodes, that includes supraclavicular nodes, that I'm going to discuss in each slide. I'm going to introduce you different stations in each slide. And number two is upper paratracheal, which includes right upper paratracheal and left upper paratracheal. Number three is we have 3A and 3P, which includes prevascular and retrotracheal. And number four is lower paratracheal, which is the node which is located in the lower paratracheal region. That is one on the right side and left side. That is 4R and 4L. And number five is the aortic group of nodes. So superior mediastinal nodes 1, 2, 3, 4. So which includes number one, number two, number three, number four. And aortic nodes, once again, two nodes are there. So one is subaortic, as the name indicates, the node that is present just below the aorta, that is subaortic node. And then para-aortic node, anything on the side, on the front aspect of aorta, is a para-aortic node, which is named as number 6, station number 6. And in inferior mediastinal nodes, if you see the order, it is numbered from upward to downwards in the same fashion. You see that this is the inferior mediastinal nodes. In this, the major one, that what we see in inferior mediastinal node is the subcarinal node, that is immediately below the carina branch point. And number 8 is the paraesophageal nodes. And number 9 is within the pulmonary ligament. So the order is superior mediastinal, the node which is close to the aorta, and inferior mediastinal, which includes from the carina up to the ligamental nodes. Then after finishing the central axis, you go on the area of lung parenchyma. You see that here you have a nodes, N1 nodes, starting from the hilum, which includes hilar nodes. That is number 10 is a hilar node. And then number 11 is interlobar nodes. The node, as the name indicates, the node which is present between the lobes. In the interlobar nodes, once again, you have a superior inferior. And then number 12 is a lobar node. Number 13 is a segmental subsegmental node. So if you start from the superior aspect up to the level of axial plane, so you have a numbering from 1 to 9. Then from the hilum to the periphery, we have a numbering from the 10 to 14. That's a double-digit number. Okay, so let's start discussing this nodal stations one by one. So number one is a supraclavicular node. That's the highest node. So this is the node like if any disease which involves the supraclavicular node, that is very dangerous, because we need to search for the active lesion elsewhere in the body. Here you have 1R and 1L, which includes lower cervical, supraclavicular, and sternal notch nodes. The whatever nodes that is here, this we classify as station 1 node. So we have a limit. That is because this limit is very, very important, because in EBUS, that the plane of demarcation is so important, so that we can name it as what station we are seeing. Whether it's station 2 or station, for example, if you are seeing a upper paratracheal, lower paratracheal, the innominative vein which is crossing the front of trachea, it's a limit. Anything that is above the level of innominative vein, we classify as 2 nodes, station 2 node, that is upper paratracheal. Anything below that, we classify as lower paratracheal. That is the limit we need to see. If you are seeing for station 1, you see the upper border is the lower margin of cricoid cartilage and the lower border clavicle. So, for lymph node station 1, midline trachea serves as a border between. So this is very important. Right-left difference. How do you classify 1R and 1L? For example, 4R, 4L, actually the classification is totally different. But for station 1, the center point, you just run an imaginary line in the center of the trachea. Anything to the right side, which is classified as 1R. Anything to the left side is classified as 1L. Then comes to superior mediastinal. In superior mediastinal nodes, we have the first one is station 2 node, that is upper paratracheal. The node which is seen in the upper paratracheal region, that is a 2R node, which includes the nodes extending to the left lateral part of trachea. Very, very important. Number 4R, you see that it is not only in the right side. It is the right side also anterior aspect up to the left side. So the line which lands on the left lateral border of the trachea up to that whatever node is there, which is classified as 4R. This is the difference. In station on what I told, it's basically a midline. Here the line is the left lateral border of trachea. Anything on that right side will be a 4R. Anything to the left of that line will be a 4L. So you see, if you see, sorry, 2L, it's 2L. So anything 2R and 2L. So anything, so here in 2L upper paratracheal, you see that which is on that line, on the other side of line, we call it as 2L. So this is how we see that in EBUS. You put a EBUS probe that is directed in the upper tracheal rings, that is 4 to 5 tracheal rings, probe oriented towards the left lateral plane. Here you could see that the 2L. You can see the line. This is the yellow line. That is the imaginary line. This line is a demarcation which demarcates 2R and 2L. Anything which is to the right side of this line, which is classified as 2R, and anything to the left would be a 2L region. And this is how in 2R, the same way, you can clip the EBUS probe in the upper paratracheal, upper trachea at the level of 4 to 5 tracheal rings. The probe oriented towards the right lateral wall. So one left lateral wall and right lateral wall. Here, that the acoustic landmark, what we see is the innominate vein. So the innominate vein is the the indicator in the scanogram. So through that only we identify the 2R12. So basically, actually, if you are a if you are a good EBUS scopist, so you should not see the white light scope. So directly you put the scope and see the scanogram and tell the area where you are seeing. The landmarks I'm going to tell in the subsequent slides. So this is a case that last I think 2 weeks 2 weeks back we had. This patient had a large mass in the right paratracheal region. Okay, so this mass is loculated. So we thought that what it might be a paraganglioma or what it might be a thyroid, ectopic thyroid. And so finally it came as ectopic thyroid. So it has a mixed colloid density, which is presented as a large mass in the right upper paratracheal region. Here actually, if there is a mass is there, it completely obliterates the innominate vein because it pushes all the anatomical boundaries. So after this station 1, station 2, we have these so-called prevascular nodes. So 3A nodes. As the name indicates, a prevascular. The node which is in front of the vessel. That is the mark. You see the area, how it looks in the CT scan. Okay, this is a prevascular node. It's a 3A node. And another one is 3P node. As the name it is retrotracheal. The node which is behind the trachea, what we call it as a 3P node. Right as upper border, the limit will be the apex of the chest and lower part up to the carina. So anything from the apex to the lower border, when it is in the posterior aspect, we name it as 3P. And the most important area that we need to sample for staging is this one. That is the lower paratracheal. We finished number 1, number 2, and the lower. This is very important. The lower paratracheal, we have a right and left side. So right side, which includes right paratracheal nodes, you note this point. All the pretracheal nodes extending to the left lateral part of trachea. This is what the point is. It is not the midpoint which differentiates right and left. It is the line which is drawn at the left side of the trachea. Anything to the right side will be a 4R. Anything to the left of it will be a 4L. So 4L, which includes the nodes to the left of the left lateral border of trachea, which is medial to the ligamentum arteriosum. This point is very important because ligamentum arteriosum is a landmark. Beyond that ligamentum arteriosum, it goes to the other station. So that point we need to note. This is how it looks. The 4R. 4R actually how to identify in the scan in the EBUS scan. Here the landmark will be usually we'll keep landmark vessel only. I told you for 2R it is the innominate vein. 2R12 you see the innominate vein in the front of the trachea. Here you see acygos vein. The acygos vein is a differentiating point because we need to keep the probe just before the branch point, before the carinal branch point, and that's a lower tracheal region. Once you enter deep inside, it goes to the other station. So that landmark will be given as a acygos vein is the cutoff that you have to note in the scanogram. This is a large, nodal. This is, I think, same patient like, we did for, that I told you, right paratracheal mass, which extends beyond the innominate vein. It's a large mass. So finally, it came as ectopic thyroid. You see in the CT scan how it looks. This is the branch point. This is the aortic arch divided into ascending and descending aorta. Here you see the one that is marked. It is a light lower paratracheal node. That is a 4R node. What we are seeing. And 4L node, as the same. It's like 4L node in scanogram, how to identify is that it's that Mickey Mouse appearance. Anything node which is in between the Mickey Mouse appearance. So you see that aorta and pulmonary artery will be there. Any node just in between the aorta and pulmonary artery as ears. So that will be classified as a 4L node. So this is a small example that the 4L node sampled with the EBUS procedure. Okay, so after finishing all these things, now we are going to deal with aortic nodes. In aortic nodes, there are once again 5 and 6 are there. The number one is subaortic nodes. As we already discussed, that these are the lymph nodes which are lateral to ligament arteriosum. I told you, ligament arteriosum is a cutoff. Before that, we have other station. Any node which is lateral to that, which is classified as a subaortic, which is below the level of aorta, subaortic. We have a landmark for this. You see that upper limit will be the lower border of aortic arch. And the lower border is the upper rim of left pulmonary artery. So between aorta and pulmonary artery, whatever node is there, which is classified as subaortic nodes. And the sixth number is a para-aortic node. Any lymph node which is anterior and lateral to the ascending aorta and aortic arch is classified as para-aortic nodes. And then comes the inferior mediastinal, our favorite nodes, which can be sampled even with conventional TBNA. That's a subcarinal node, very easy to sample. You see that if you see a subcarinal node, if you see a large node, here also a problem. Like if you see a large mass, we need to station that properly, because to stage them properly, we need to station that properly. For that, we need to know the limit. So far, we can label this as station 7. So if we see the subcarinal, upper border limit will be the carina of whatever the carinal branch. And the lower border is the upper border of lower lobe bronchus. So anything from the carinal branch point up to the origin of lower lobe bronchus, any lesions what you are seeing, any nodes what you are seeing is classified as subcarinal node. Very easy, subcarinal node is easy to sample. You can sample from the right side and left side. Okay. The important landmark what we see in the EBUS scan is you can see the cardiac pulsation. You can see the pericardium. You can see the left atrium. Everything will be there easily in the subcarinal area. With that, we can identify the subcarinal station. Okay, you can see that this is subcarinal node. You can see the cardiac pulsation very well seen. You can see the so here one thing is that if the node is very small and if you are doing it precisely, make sure that the needle should not cross your the extent of the lesion, because immediately below that lesion you see the pericardium. Sometimes you may track the pericardium, you may have a pericarditis and some complications may be there. But usually EBUS is a very safe procedure. And even if you put the needle into the aorta also, nothing is going to happen. That's what I just want to convey. One of the simple procedure if you know the anatomy, and learning to is also very, short. Out of all the IP procedures, EBUS is one of the procedures that you need to master, and learning to also very short. And station 8 is a paraspinal node, the lymph nodes which is adjacent to the wall of esophagus to the right and left midline, which is excluding subcarinal node. Very, very important, because this is close to the esophageal area, which should not include the subcarinal nodes. That is the point that you need to note. And number 9 is the node which is lying within the pulmonary ligament. And the last is that we have completed all the central axial nodes. And last is the nodes which is from the main bronchus up to the segmental subsegmental bronchi. Anything nodes which is present in the main bronchus is a hilar node. That is a station 10 node. And which includes nodes immediately close to the main stem bronchus, which also includes a node which is close in the proximal area of all the major vessels, which includes all the pulmonary veins and artery. Any node which is close to that is classified as hilar node. This is station 10. This area. So we have station 10R and 10L. So on the right side and the left side. Next is interlobar. Interlobar, I told you, any node which is present between the lobes. So here once again, we have, if you see in the left side, so it is between the origin of left upper and lower lobe bronchi. If in the right side, you see that superior and inferior, we have differentiation. So any node which is present between the branch point of upper lobe bronchus and bronchus intermedius, that is a superior one. Anything between the middle lobe and lower lobe, it is a inferior one. Then comes 12, 13, 14, that is lobar segmental subspinal bronchi. So starting from the highest station to the central axis, then starting from the main bronchus to the segmental subspinal bronchi, we classify the different stations. Then a short overview on how to do EBUS TPN. I think this will be very well dealt during the time of workshop, because with the scope in hand, it's very easy to master. If you know the normal white light bronchoscopy, EBUS is nothing. You know the normal ultrasonography, basics of ultrasonography, and know how to handle the scope, normal white light scope. It's very simple to do a EBUS. There's just a small video which can give you a 3D.
Cancer has 2% of patients. For a purpose of confirming a diagnosis, subtyping the and absence of status of involvement. Flexible view is limited to the airways.
This is how we go inside. So before doing a EBUS procedure, the main important thing is that you need to make the area very well for scanning. So for that, you need to support all the secretions. There should be no atelectasis. So normal white light scope is very important, because sometimes you may see a large mass also, the endobronchial area. So we need to sample that before the mediastinal sampling. We need to see that also. So white light scope is the must for all the EBUS procedure. So after performing the white light bronchoscopy, then you scan that the mediastinum. Okay.
Provided transbronchial needle aspiration, the more invasive.
So this is how you see that the stations,
including 10R, 10L.
So these are hilar nodes. You see that these are interlobar nodes.
By other more invasive techniques. EBUS is indicated when initial symptoms warrant pathologic CTs for a axis are sampled. The same fundamental in a study.
So anything above 5 mm actually is, be considered pathologic. If you suspect a disease, anything above 5 mm is considered pathologic, and it's always better to sample the node.
An improved procedure. Once the apex of the vocal cords is visible as the scope enters the subglottic space. As the bronchoscope approaches the cords.
So the difference between your normal scope and this thing is the angulation and the maneuverability. So because like EBUS actually it is not so flexible because of the distal probe is there. It is not so flexible as you just do with the white light bronchoscopy, normal bronchoscopy. So what you have to do, it will bend like that. So you have to do in that way only, like as you play a game. It will be like that. Once you do 4-5 procedures, it will be, you can get well versed.
Finally, and the image of the target lymph.
This is the way. So most of the times while handling the scope, the lever has to be pushed so that the probe has to be in proper contact with the airway wall. Because you have to scan the airway wall. From the airway wall only you are scanning the mediastinum, complete mediastinum. The contact of probe is very, very important. So for the better contact, we have a balloon. So if we have a balloon, the balloon has to be inserted around the probe and it is to be inflated with saline, and that balloon will create a good contact with the airway wall, which will provide a good imaging. Okay, so I think that how to do the procedure and how to fit the needle and all, we will show you in that in the workshop. I think some of the cases, I think subsequent speakers are there. They will show you. So what I'm going to tell is that how to systematically examine a patient once you get a referral for EBUS. This is very, very important, because normally what we are doing a hit and run technique. What is hit and run? Hit and run means whatever node you are seeing in the CT, a large node close to the lesion, or whatever node you are getting a positive node in a PET CT, these nodes we are hitting. Actually, that is not the protocol. Because sometimes PET may fool you, actually, even 10% of cases. If you want to have a good, staging, you need to have a systematic way of doing a scan. You see, this is a systematic way. There are 6 landmarks in EBUS. You should not forget. All these areas has to be scanned. If the node is there, all this area has to be sampled. Very, very important. Starting from the left side to right side, you have to scan the 4L and station 7, then 10L, then 10R, and then you see the asagas and 4R. So you have to scan in that way, that from left side to right side. There are different, vascular landmarks for all the stations. For 4R, I already told you, asagas is a landmark. And the asagas vein you should see like this. And then 10R is the node that right hilar node that you have to see. And then 4L, I told you, it is like a Mickey Mouse. There are two big major vessels. Between that, you see a node. And then station 7 is a large node, the pulsation of heart, pericardium, and left atrium you will see. And then 10L, you see that same like this. The procedure, I think we will discuss in the workshop time. And then there is always a debate, like once you puncture that, after focusing in the ultrasound, once you puncture that, whether we need to do a negative section or not, that also we'll discuss in the panel discussion. I think the staging also very important. So after lymph node, anatomy and lymph node stations, staging is very, very important. This stage you should not forget. I think all the PGs, you see that TNM staging. That is the common stage system we follow for the classification of lung carcinoma. You see that as the name indicates, T and M. T for the tumor, N for the node, M for metastasis. You see that this is a TX. TX is a tumor in the sputum or bronchial washing where you can't see the tumor in imaging and bronchoscopy. T0, there is no evidence of tumor. TAS is the carcinoma in situ. In T1, we have any tumor which is less than 3 centimeter. It is surrounded by a lung and visceral pleura, not involving any main bronchus. That is it's a peripheral area that is there. In that, we have once again three sub classifications: T1A less than 1 centimeter, T1B 1 to 2 centimeter, T1C 2 to 3 centimeter. And coming on to T2, anything less than 3 centimeter is T1. From 3 to 5 centimeter is T2. So here you see the involvement of left main bronchus without the carina, regardless of distance of carina. Previous classification, they were telling this much distance of carina. Now they have removed it. And invasion of visceral pleura also will be there. In that T2, once again, we have two classes, 3 to 5. In T2A, it is 3 to 4. T2B is 4 to 5. And T3, it is any tumor between 5 to 7 centimeter. Less than 3, 3 to 5, 5 to 7 centimeter with the greatest dimension. Or any tumor of size that involves a chest wall, pericardium, phrenic nerve, or satellite nodules in the same lobe. Very, very important. Any satellite nodule in the same lobe, which brings the tumor to the T3 stage. T4, any large lesion more than 7 centimeter, or any tumor of any size with invasion of mediastinum, invasion of diaphragm, heart and great. These are the major structures. We can't operate at anyhow because we can't remove the cardiac, heart, the great vessel. So this comes as T4. Recurrent angina, carina, trachea, all these are major areas. If that involves, then we can classify that as T4. Coming on to end station, this is what we discussed all the things in the lymph node station and the basics of doing a EBUS also to find out what stage the patient, to identify the end to entry stage. That is the importance of doing EBUS staging. So here we have N1, N2, N3. N1 is a peripheral, that is the stage 1, that is the peripheral, that is ipsilateral, peribronchial and hilar nodes and intrapleural. Any nodes which is distal to the distal area, which is classified as N1. N2 is anything which is close to the axis. From the periphery, it has gone to the center. It involves the mediastinum and subperennial nodes. That is a N2 node. N3 node is higher nodes. That is contralateral mediastinal hilar nodes, or ipsilateral, you see a scalene or supraclavicular node. That is a N3. So N1 is peripheral node, which is close to the bronchi. N2 is mediastinal nodes and hilar nodes. N3 is opposite side node or any side supraclavicular node. So coming out of the metastasis M classification, previously we classified as distal metastasis only. Now in that also we have a classification M1A, 1B and C, 1C. M1A tumor is a contralateral lung or pleura, pericardial node or malignant effusion. We classify as M1A. M1B is a single extrathoracic metastasis, including a single non-regional lymph node. M1C is a multiple extrathoracic metastasis in one or more organs. So we classify that as. So this is a permutation combination. Based on that, we stage the patient. So we include all the T, N and all. And then we classify as 1A1, 1A1, 1A2, 1A3 based on the TNM information. Here, these are the major changes that you need to note in the TNM staging in the 9th classification. N2A is a single station N2. N2B is multiple station N2. This is very, very important for treatment aspect. And N2A with T3, which is classified as 3A. N2B with T2 is classified as 3B. And here you see that M1C, once again they categorize C1 and C2. Actually, you may ask one question, sir, why to categorize this in a fine way? Because all this we are doing for better treatment options. Because if you want to optimize the therapy for a better chemotherapy, or you want to fix the patient for radiation field and all, we need to stage the patient appropriately so that the treatment will be adequate. So just a recapitulation, you see the TNM staging by a simple diagrammatic representation. You see T1A, T1B, and T1C, 1 centimeter, 2 centimeter, 3 centimeter. T2, 4 centimeter, 5 centimeter. T3, greater than 5 centimeter. T4, more than 7 centimeter. This is T. And in T2, you see that any tumor with visceral pleural involvement, any tumor with obstructive lesion causing atelectasis, any tumor which causes a main bronchus involvement but without involving the carina. In T3, once again, a recapitulation, you see any tumor between 5 to 7 centimeter, any tumor with chest wall invasion, any tumor with a phrenic nerve and parietal pericardial involvement, any tumor with diaphragm invasion. So we classify as T3. And in T4, you see that a tumor which involves a major axis, carina, tumor involves the trachea and SVC, tumor which invades the major vessels like aorta, any tumor which is a larger size more than 7 centimeter, tumor which invades the vertebral body, classified as T4. So here, most of the times, once you stage a Pancoast tumor, there is a doubt that many of the times, like we may face a situation like T3, you have a chest wall invasion like this. In T4, if you see MRI for this Pancoast tumor, in T4, if you want the patient on T4, when you do MRI, you can very well see the invasion of major structures. The subclavian vessel encasement will be there. Involvement of brachial plexus will be there. That classifies the patient from T3 to T4. That's why just a plain CT illada, you need to ask for an advanced investigation to see all this involvement so that which makes the patient to upgrade the stage. The same way you see, very simple classification, N3. Any involvement above the supraclavicular, that is, anything in the higher stations is N3, and the node opposite side of tumor, that is, station 2 to 14. Suppose the patient is having right side lesion, having a node in the left side. From station 2 to station 14 is classified as N3 only. N2, very important, all the subcarinal node, which is classified as N2, station 7. And node on the same side of tumor, that is station single digit station from 2 to 9 is classified as N2. You are getting this point? All the single digit station, that is 2 to 9 on the same side of tumor, and the subcarinal node is classified as N2. N1, all the double digit stations on the same side. So the patient is having a right sided tumor is there. So all the double stations from the station 10 to 14, which is classified as N1. So N1, N2, N3. The same way M1A we can classify. So why we use stage all these things, and the lymph node stations is very important because it will decide your treatment plans. It will decide your options of treatment and how to follow up and to decide like how long the patient is going to live. So these are the different methods we use for staging, but commonly what we use is PET-CT. I think many of you are working with working in the patients with lung cancer. We do PET-CT scan. But what we are doing EBUS is only we are doing just to target the lesions which are lighted up by PET scan. But that is not the correct way of doing a staging. Because doing a upstaging and downstaging, both are dangerous. If you do a downstaging, you are denying a proper treatment for the patient. If you're doing upstaging, you are doing aggressive treatment for the patient. So by anyhow, we have to fix a proper staging protocol. With EBUS, it gives excellent staging because sometimes in 10% of cases based on the various data, that occult nodal metastasis may be there. That means that PET may be negative, node may be there. But we think that the PET is not showing light up, so we don't sample that. It is not the right way of doing a staging. So always you need to sample. So my way is that you need to sample all the main stations, that is 4R, 4L, and station 7. That's a must. Any node which is more than 8 mm in the CT or in the EBUS, or any node which is just close to that area, these nodes, and then any node which is having character of that is classical round shape, heterogeneous, and all this proper well-defined margins, any other features, vascularity, based on that different character of node, we need to sample. So the nodes which are showing light up under clinical workup, you do a sampling, and then any node which is not showing light up in the PET scan, but still all this 4R, 4L, and station 7 has to be sampled if the lesion is more than 8 mm. This is a big term. Why the staging is important? Treatment options are stage dependent. Prognosis also depends on stage. Enrollment of clinical trials also depends on stage. Always for the it provides a very important platform for the discussion that is there. So these are the different tools we use for staging. That is EBUS, EUS, and surgery, and then CT and PET scan. What is the drawback of EBUS actually? There are some stations which can't be assessed by EBUS. That is the only thing. So you see that station 5 and 6, we can't assess with the EBUS, and station 8 and 9, we can't assess with EBUS. But otherwise, all other stations can be targeted with EBUS. When you combine with the EBUS, endoscopic ultrasound, so we can very well perform EBUS with our same EBUS scope only. In that, we can target all the other nodes. So by this EBUS and EUS, endosonography, we can almost target all the lesions, and we can give a good stage to the clinician who are treating that patient for a better treatment protocols. And of course, surgery gives access to every nodes. I think this all the needle types and all they are going to discuss, and the cryobiopsy is a separate talk that they're going to discuss. And very important thing, lung cancer is a leading cause of death, and EBUS staging is one of the important diagnostic tool for mediastinal stations. It dictates your treatment options and prognosis, and treatment varies depends upon the different stage. That's why there's you need to give importance to the staging, and you need to revise your staging methods also depending upon the time and depending upon the patient's perspective. And multiple tools exist for the diagnosis of lung cancer that you should not forget. This is the last recent case that we faced. This is a patient. With this, I'm going to finish. A patient, 60-year-old male, presented with a single a nodal mass that is there here. You see that? You tell me how to approach this, I think. Can you see here? Answer. Can anybody tell me what is the station? This one.
Station 6. Station 6.
Yes. So how to approach this?
Transaortic.
So this patient, actually, I'll tell you what are the problem he's having. He's a CKD patient on dialysis. He is also a CAD patient on multiple antithrombotics, non-Parkinson's, but patient is a good patient. Like patient attenders are well educated. They want to do the procedure. They want to rule out malignancy. He's also having 1.5 fever was there. So how to approach this lesion? Jagesh?
EUS.
So there's no other because this patient also have ILD also. I think I'll show the lung cut. He also have fibrotic ILD. So this patient, what we did,
Transaortic with a
patient
22G
actually
needle.
we got a plain we punctured aorta, pulmonary artery with single pass, and then entered into that. So finally came as the chronic inflammatory pathology, the plenty of histiocytes, suspected tuberculosis. So we actually worked out for that. So this you see that a needle is needle is passing because anesthetists were very reluctant to give fitness for this because CKD patient on dialysis they tend to bleed. We see that a needle is passing across the the major vessel, that's a pulmonary artery, and then it is entering into the lesion, and successfully we got diagnosis with that. So what I'm trying to convey is that EBUS is actually a the basic procedure I think everyone should learn, and EBUS is very safe. Even if you put the needle into the aorta, that too, this patient is having a lot of bleeding disease. Okay, nothing has happened. There's a small gush was there. I think my PGs are there. They also saw this case. So when the vessel is very thick, once you put a needle for 22 or 25 gauge, nothing will happen. Nothing is going to happen. This is a simple gush. Unless you are going to put a needle in a aneurysm, or the patient is having severe PHT or something like that, then only you will be under trouble. Otherwise, it's very easy and safe. And post-op also we have followed with this case because we want to know that whether any mediastinal bleed and this. So we have nothing has happened, and then patient is doing fine. So with this, what I am trying to convey is that any IP procedure is you can master, but before that, try to be very strong in basics. And for doing EBUS, the basic anatomy is very important, and you need to know the different lymph node station. Doing a EBUS and puncturing the node is not a great job. Anybody can do. I think you can sample the EBUS nodes in a matter of when the anesthetic give fitness and everything. You can sample it in a matter of 5 to 10 minutes. not a big issue. But thing is that which node has to be sampled, and what ideally, what are the systematic way of doing EBUS is also very, very important. That's what I told you. Any node size which is close to the subkernel area, that is the N2 target, subkernel region, and then 4R and 4L nodes. All these nodes, if it is more than 8 mm, even it is PET negative also, don't ever leave sampling that nodes. You sample that node, you will get a big surprise at the end. That's it from my side, ma'am. Thank you.
Thank you, as usual, Dr. Ivarajan, for that making that difficult topic very simplified. But I would say he just told puncture the iota, things like that. Don't go and try it tomorrow. If you don't have a good backup, you don't have a good setup, you should have a backup of a CT surgeon. Suppose something fails, and you should be an expert. He would have done so many EBUS. After that, you would have tried this. Tomorrow, don't learn EBUS today from the workshop. Tomorrow, don't go and puncture the iota. It needs a learning curve. I think he'll accept with that, right? So you need a good backup and a good setup. That should not be the message across. He has got away with it, but be careful on doing all that. If you have the backup, if you have the expertise, go for it. Because he has saved the patient from doing a mediastinoscopy. Otherwise, this node would have been approached only by mediastinoscopy, which needs anesthesia, which needs a surgeon, and complications and side effects, keeping the fibrotic ILD. That's the message he's saying. So not that he doesn't want to do, as such, if you leave this patient, this is an ideal candidate for mediastinoscopy. But then, because the patient has fibrotic ILD dialysis, he told you the clinical scenario. That's one thing. Any questions from the floor? I don't think you should leave Dr. Ivarajan like that. He has got an expertise, extract something from him. Okay, I would like to ask a question. So you said systematically sample 4R, 4L, start from there.
Yes.
So each time when you go to a node and you come out,
Yes.
you use a separate needle or use a different needle?
Ideally for staging EBUS, I think you need to have a separate needle, because it is very important that you should not contaminate the needle, because if you want to have a staging EBUS, if the patient is having a right side lesion, you need to sample that worst area, worst possibility. Then the left side you have to sample. That means that left side is whichever node which has the least probability of getting a metastasis, you have to sample that first. Then finally you have to come, because you should not puncture that and then you have to
For each
contaminate.
node, you use a separate needle.
Yes, it's always better, ma'am.
That's the best.
It is better.
So the cost factor goes up.
Yes. Yes, ma'am.
Okay, fine.
Ideally for staging EBUS, what the guidelines are recommending, if you are not thinking of the cost, it's better to use a separate.
As per guidelines, it is you have
Yes,
to use a separate needle, because some leftover thing will be there. and then
for
the next
each
one-
node, 3 pass at least to be there. For each node, if you are suspecting, 1 pass is not enough. 3 pass has to be there. So if you are targeting that 4R 4L, so 3 pass has to be taken for that each.
The other thing is, so suppose the PET is positive and you have done staging through the EBUS, it comes negative. Are you good to go for the surgical excision, or would you like to do a mediastinoscopy before that? Because this is a controversial
Yes, ma'am.
topic in the
Yes,
guidelines.
yes, ma'am. Actually, this type of cases, actually, you need to see the clinical scenario as a whole. See the node involvement, see the adjacent nodes. If the PET positive correlates with your complete clinical picture, EBUS is not a 100% specific diagnostic test. Any test for that matters. It depends upon the person who is doing the procedure, depends upon the node characteristics. Because some nodes will be juicy, will get a lot of material. Ma'am. Some nodes, by any of, like if the node sonographic character is not matching with our malignancy properties, so you may miss the the malignancy. So in that thing, that actually there are a lot of difference of opinion with the surgeon, that surgeons are telling that after opening of the thorax, taking the node in hand, that gives 100% evidence patient to upstage or downstage the patient, because many a times PET may be negative, EBUS may be positive, and sometimes, as you told, you may have a false positive EBUS also reported. But in that case, that is extremely rare phenomenon, the false positive, because sometimes that's why white light bronchoscopy has to be done. I told you, ma'am, because sometimes that endobronchial disease may be there. In that, malignancy cells will be there. Once you pass the needle, the malignant cells will contaminate your needle, and then it will get punctured into your node, and you think that it is from the node, but it is not from the node. It is from the carcinoma in situ what we are dealing. So that's why white light bronchoscopy. So the best thing will be until you go
Surgical.
inside surgical excision and see that the staging may be different.
Another caveat is when you do a EBUS, you're only taking a needle aspiration. There can be micro metastasis in different part of the node. Yes, so we might miss. So even though all is negative, it can still surgically be positive. As you said, the right thing is only surgery. The other thing is you made it very simple, saying that subcarinal you do, but within that subcarinal nodes, you can have 7 to 8 lymph nodes.
Yes.
So how do you really choose?
Ma'am, actually, that's what, ma'am. So within the subcarinal area, if you see, at least is each station, you need to stage 3 nodes. So if you are having 5 nodes, at least 3 nodes. The 3 nodes, how to select? You have to see the property of node. That's what that there comes the your sonographic knowledge. So you see that the wall, if it is well defined, rounded, margins are good, having heterogeneous nature. So don't select a node which is not having heterogeneous. If you see a node having a multiple different shades, as you see white, dark, pattern, and then see the vascularity. Any node which is having good vascularity, having a different heterogeneous nature, having a good margin and the sharpness, definitely puncture the node. So whichever node follows this criteria, at least 3 nodes has to be sampled from the station for the better, finish.
So, between FNAC and biopsy,
Yes.
now we are using cryo in
Yes.
EBUS, right? So for staging, do you use cryo as well? If so, then how many cryos do you do?
Ma'am, actually, cryobiopsy actually at present staging cryobiopsy actually very few centers they have tried, because cryobiopsy itself, once you do that, it is actually people used to get afraid because no control is there, because you are pushing that thing. But till now we have done a lot of cryobiopsies, nothing has happened till now. But it may the thing is that risk of bleeding is there, and you can't make puncture in the multiple areas. So at present, cryobiopsy, what we are doing is mainly for the diagnostic purpose. Like if you see a target lesion, single node is there. If you want a diagnosis from the node, if you want a better sample for molecular profiling, so you better go for a cryobiopsy. But if you want to puncture multiple areas in the mediastinum, it is always better to go with needle. As madam was telling, needle, what is the drawback is that there are micro metastases there. Once you put the needle, if the metastasis is away from the tract, we may miss that lesion. We may miss it. So for that only, we are doing a fanning technique. If the node is large, what happens? Like once you put the needle inside, you just rotate the scope and with the lever, and then make the needle pass in a different direction of the node within the node, so that you don't miss not even a single area. You go like this way, like that. So you sample all the areas within the node. The chance of getting a positive result is very high. In that aspect, actually, people used to argue that cryobiopsy, if you do that, it will track only that area only. The only advantage of cryobiopsy is that, like it is a circumferential, the ice formation. So the tissue that is obtained from that is basically a circumferential one. So till now, actually, the diagnostic yield is very good, but the school of thought is this only, because we can't, tell it is good for, it will replace needle aspiration.
Dr. Yuvraj?
Thank you. Thank you, Rajan. Very
Dr.
nice.
Yuvraj?
Thank you.
Thank you, Chairperson.
Yeah.
May I request Professor Raghunandan, sir, please come over to the dais and give the memento to our Chairperson and the speakers, sir.
Dr.
Welcome, sir.
Yuvraj?
First, Professor Yuvarajan. Come.
Dr. Yuvraj?
Thank you, Professor Yuvarajan. Very nice, wonderful startup. May I request Professor Raghunandan, sir, please give the memento to the Gayatri ma'am. And next, Tilagodi ma'am and Surja ma'am. Thank you. Thank you all. We'll move on to the next session. Before going to the next session, we have a quiz.
So how many postgraduates do we have? Can you guys raise your hands? I can see only predominantly MGM postgraduates. Great. All right, fine. Over there behind. So we shall shoot out some quiz questions right now. All right, some quiz rules, all right? If you guys know the answers, please raise your hand. Do not scream out the answer because I'll not be able to identify who answered. Please raise your hand. And once I call out that person, get up and scream the answer out loud. In case you guys get the answer right, you will not be allowed to participate in the next following questions, all right? You have cash prizes involved. In case you get the answer wrong, the question will be passed over once, all right? Not more than that. Are you guys ready? So coming to the first question, which of the following is the most accurate statement regarding the use of roflumilast in COPD management, particularly for patients with frequent exacerbations and significant chronic bronchitis? Roflumilast is a long-acting beta agonist that improves lung function by targeting beta-2 adrenergic receptors. Roflumilast is an oral phosphodiesterase inhibitor that reduces exacerbation rates by decreasing inflammation and mucus production. We already have takers. I saw a PG in the black shirt. Can you get up, introduce yourself, and tell the answer, please? Good job. All right. You can give him the cash prize.
Give the cash prize to.
Your name?
Name, doctor? Good name? Good name, please? Anand. Anand. Dr. Anand. Congratulations.
Congrats, Anand. Moving on to the next question. In the context of asthma phenotyping, which of the following advanced imaging techniques provides the most detailed view of airway remodeling by visualizing changes in bronchial wall thickness and airway lumen narrowing in vivo? A. High-resolution computed tomography with contrast. B. MRI with gadolinium enhancement. C. In vivo confocal microscopy. D. EBUS. We have a postgraduate there.
Confocal microscopy.
Good job, good job. Congrats. Your name, please?
I'm Dr. Surya Prakash from KMC. KMC. Congratulations. Right.
All right, coming to the next question. Which of the following emerging therapies targets the IL-33 receptor and aims? We have a taker here. I'm sorry. All right, fine. Okay, since he answered it off immediately, it's passed on, so you can give it to him. That's Ibrahim from MGM, who's a postgraduate. Now we have a question for the faculties, all right? All the senior faculties over here. A recent study has identified a novel gene variant associated with an increased risk of IPF. This variant affects the regulation of a specific cellular process linked to fibrotic responses. Which of the following gene variants is now recognized as a significant risk factor for IPF, influencing the TGF-beta signaling pathway? Please raise your hands if you know the answer. Faculties, senior consultants. I'm sorry, ma'am. That's not the answer. One more attempt. Jackin, sir? Yeah. TERT, great. Yeah. Sir, if you would like to elaborate about the TERT. Okay.
Congrats, Professor Jackin Moses. Good.
So the TERT gene normally helps in telomere shortening. So if there's a mutation, it affects the shortening. All right, congrats, sir. You can hand over a prize to faculty Jackin, sir. Thank you, sir. Yeah. Yeah. Before we move on to our next session, I would like to invite our chairpersons, Dr. Jackin, sir, who consults in multiple places, not just in one hospital, multiple
So Jackin
hospitals.
has more than 10 years experience. He is working in the Frontier Lifeline, SPM hospitals, and he is interventional and a clinical pulmonologist. Please welcome.
Dr. Harish, sir, who's a head and consultant at Kaveri Hospitals. Dr. Anbamaran, sir, associate professor at Savita Medical College. I take immense pleasure in welcoming our next speaker, not only on behalf of MGM, but also on a personal front, who has helped modulating and been a momentous person in shaping my career. I welcome our beloved Professor Dr. Irfan from Ramachandra Medical College to take over the dais.
Harish, you can.
Good morning, everyone. Thank you, Dr. Irfan, for accepting the invite for the talk. As we know, Dr. Irfan is a professor from the Department of Pulmonary Medicine in Ramachandra Medical College, and his interests include pulmonary physiology, sarcoidosis, ILD, and intervention pulmonology. We all know him to be a voracious speaker with a lot of interesting anecdotes. Over to you, Dr. Irfan.
Thank you. Thank you to the honorable chairpersons, and thank you, Dr. Deepika, for the introduction. So, without any further delay, I'll move on to my topic today. The topic is on, let's break it down, linear probe EBUS from the practical standpoint and case examples. When I was given this topic by Dr. Jayaraman sir and Dr. Deepika, I was actually not very sure what I was supposed to talk on. What I tried to understand was they were trying to say, try to share my learning curve so that it will be easy for postgraduates to understand also what we should learn along the way when we're doing endobronchial ultrasound. So, acknowledgement, I'd like to thank the organizing committee for inviting me to be part of this World Lung CME Day. In terms of EBUS experience, when you do a PubMed search, you will find that there's around 160 publications as of yesterday. The first one, which was published in 2009 by Dr. Bala Mugesh sir in CMC Vellore, along with Dr. Hurt. That was an introductory write-up on what is endobronchial ultrasound, a new innovation in bronchoscopy in 2009. Subsequently, around 160 publications, and initial publications usually were case reports. Subsequently, they started talking about experiences. We had our first publication in 2014, where we shared our initial experience with endobronchial ultrasound from a tuberculosis endemic population, where in 102 patients for whom we have performed EBUS, we found that an overall adequate sample was obtained in up to 96.1% of patients, and it was diagnostic in 80.9, 84.8, and 75% of patients with sarcoid, TB, and lung cancer. Our experience was relatively poor in the sense that we were getting a poor yield in malignancy, but we got a reasonably better yield in sarcoid and tuberculosis, but still less than the paper that came out just a year before by Neil Navani in NHS. But subsequently, from this 2014 paper till now, that's around 10 years from the time that I've started practicing, I've learned a lot of things along the way during EBUS. And I feel that this would be an appropriate stage to share these experiences so that we could probably learn along the way how we could perform this procedure with much more accuracy as well as better diagnostic yield. So I'll start sharing off first with sedation. I have now tweaked my sedation protocol for EBUS. The initial recommendation is that you give a sedative and you give an analgesic. A sedative makes the patient sleep. So an example is midazolam, and an analgesic is something that makes the patient feel no pain. You give fentanyl. So initially, I started our EBUS procedures with fentanyl, midazolam, local lignocaine, and lignocaine nebulization. But then now, if you look at the recent papers that came out, the local lignocaine nebulization is now out of practice, and they have removed lignocaine nebulization. Now it's fentanyl, midazolam, and only local lignocaine spray as you go. But now there's a re-emergence of cricothyroid injection of lignocaine, therefore giving better patient comfort and also better bronchoscopist comfort in performing the procedure. Subsequently, in my center, I have not been permitted to use fentanyl because of NABH and JCI in the bronchoscopy suite, because we are not using an anesthetic, we do it under IV conscious sedation. So as a result, now I tweak my procedural anesthesia using midazolam. I give 2 milligrams. I top up to around 3 to 4 milligrams at 1 milligram top ups every 15 to 20 minutes. I give a liberal local lignocaine, but not more than 20 mics. and I give lignocaine nebulization, even though it is out of farce in terms of the recommended guidelines. With this, I do get reasonable sedation. I get reasonable anesthesia also, but I don't have any evidence to suggest that this works, but or whether this is recommended. The other context, of course, is doing a EBUS under general anesthesia with a LMA, which is quite commonly performed in multiple centers. Coming to the second part of my talk, what have I learned in terms of taking samples from the different nodes? There are different tricks for different nodes. I think Dr. Yuvraj has set the stage in terms of basic approach to the nodes. What I would say is that the easiest nodes are 7, 4R, and 11L. So if someone who's starting out to do endobronchial ultrasound, start sampling 7. Always start sampling 7. 7 is the easiest because once you put a probe there, you're going to see the node. There's no vessel there. The heart or the pericardium and the left atrium that Dr. Yuvarajan sir was showing is quite far away from where you're going to pierce the node. You'll have a depth of at least around 2 to 3 centimeters. It's quite safe, it's easy to sample. Relatively easy nodes are 10R and 10L because you just need the landmark. Again, the landmark is important here. You take the cutoff from the carina, opposite to the carina on either left side or right side lateral wall, you touch the scope, you will be able to pick up the nodes. Now, nodes which are slightly difficult in terms of a learning curve is 11R and 4L. Now, why is this difficult? Because 11R is very close to 2 major vessels, and 4L is even much more closer to even much more major vessels. So I thought I'll just touch these 2 nodes in terms of experience that I've learned over the last 10 years when I was doing EBUS. And this is a conventional TBNA from 11R. You can see this is a secondary carina. You can see the right upper lobe takeoff, and here the one below is the intermedius bronchus. We are using a histology needle, conventional TBNA needle from Olympus, which comes with the 19G core needle, which is the outer needle. And you can see the outer needle has now come off from the sheath. And then I withdraw the needle and I take the inner needle, which is the 21G needle, out of the outer core. So you can see a smaller tip which will come out of the bigger needle there in the tip. Now using this smaller needle, we pierce the 11R station. Now this is a blind technique. I did this almost 6, 7 years ago when we didn't have EBUS in SRMC at that point of time. So you can see here that I'm piercing the secondary carina, the junction between the right upper and the intermedius. I'm using jab and piggyback technique, and I get the needle through and through the node. Subsequently, I'm doing revolutions within the node, trying to get an EBUS, trying to get a transbronchial needle aspirate. Using negative suction, I use a negative 20 pressure, which is being applied. And once I withdraw the needle, I would like you to observe the right main. You start seeing a lot of spurting of blood from the right main. You can see that I'm just literally just holding my needle there. I'm taking in the smaller core inside the bigger core. And then I withdraw the sheath out so I can see the sheath. I take the needle in, and then I withdraw the sheath from the working channel of the scope. While all this time, you can see blood just spurting from the right main bronchus. And I'm pretty much relaxed. As what Dr. Yuvarajan sir was saying, bleeding is not much of a major issue here in terms of TBNA. So I go back into the right main, and you can see that there's still blood spurting here. Now, the lesson from this node is that this node is very close to major vessels. See, if you look at the architectural anatomy of this 10R node, it will be like you have a right pulmonary vein, you have a right pulmonary artery, and then you have this green color node, which is just sitting between these 2 vessels. Now, no same patient will have the same anatomy. In other words, what you see in this picture may not be there in every other patient. Sometimes you see the node between the 2 vessels, sometimes you see the node away from the 2 vessels. It's like God twisted this anatomy here in the intermedius, at the junction of 11R, therefore making it technically challenging if you're doing a blind TBNA. I had a professor who once told me that if you're doing a blind TBNA from 11R, it's probably you're just going to get blood. So how do we avoid this? That's how EBUS helps. But sometimes what happens in EBUS is that you get a very small window because you have 2 major vessels and you have a small node. And this is where you tend to do a semi-blind EBUS where you still have visualization, but you're not getting proper image of the node. So if you look at the first picture, you can see the needle enters into the vessel if I were to keep it there. But if I bring the scope back out, you can see that the needle will then enter into the green color node. The red color needle enters into the green color node. So you can see that if I bring the scope back a bit of the ultrasound transducer will not be in contact with the mucosa, which means that I will not see the node properly. Now, this is an example of sampling of the just excuse me, I was not able to tweak this video. So here you can see the 11-hour node, and if you look at the sorry. So this video alone is not actually showing, so that's a problem. So here I'm showing you the 11-hour node. And if you look at the right side of the picture, you can see that there's an artifact. You can't see much because there's air there, because the ultrasound transducer is actually shifting away from the contact point with the secondary carina. So you can measure this node. This node is the 11-hour node. And subsequently, we try to take a pass from this node. So So when you're trying to pass a needle through the node, you can see that on the right-hand side, we're not able to get contact. Because of that, what will happen is when the needle comes out, you'll not be able to see the needle entering into the node because half of the image actually goes away from contact. So this is an example where you actually do EBUS with partial image picturization and partial guessing work, where when the needle is coming out, you're not able to exactly have contact with the node. This happens especially when the node is exactly at a junction, like say, for example, intermedius with the right main bronchus. And this happens also in the carinal area, but in the carinal area, this problem does not occur because we don't have major vessels there. So here you can see that as I'm trying to get the needle in, I lose contact, I don't have vision. And subsequently, when the needle enters, you'll be able to see that the tip of the needle will be entering into the 11-hour node. So this is the 11-hour node. The needle is trying to enter here. You've seen the needle enters, and you have a major vessel here, and you have a major vessel here as well. My apologies for this video. It's not loading since I've shared it here. So now coming to the second node that I want to share is the 4L node. The 4L node seems relatively simple because you have a straight airway, and you have the node sitting between two major vessels, namely the pulmonary artery and the aorta. So here, when you have contact with the node, you are able to see the node clearly. But the problem here is that when the node is very small, and when you get the sheath out, the sheath actually pushes your transducer away from the mucosa and therefore makes you lose contact. So when you're trying to get the needle and the sheath out together, what happens is that at the end, you might not be able to get good visualization, and therefore it becomes partially a blind procedure. I'll give you an example here where this is an example of a 4L node. You can see the large major vessels here. This is the aorta here, and this is the pulmonary artery. I've angulated the node in such a way that we are able to see the node in a cross-sectional way, axis. And this node is relatively big. If you look at the size on the side, you can see that it's 2 centimeters node. And as the sheet and the needle gets into when the needle enters into the node, you can see that the node is easily punctured by the needle. And you can see that stellate is being passed through as we try to push off the bronchial epithelial cells through the needle. Now, the same node, I've zoomed it here. You can see that now we have changed the depth here to 2 centimeters here. So the large node here, and this is the pulmonary artery, and this is this is the pulmonary artery, and this is the aorta. So here you can see that when you look closer, you can see that there are actually major vessels, small vessels, intranodal vessels inside the node into this 4L node. And these type of vessels usually do not bleed when you take aspirate. Even if it bleeds, there's nothing to worry about because the bleeding usually stops. The only thing that you should be worried about is that when you take a sample from this nodes, you might get a hemorrhagic aspirate, so you might try to avoid using suction. So here, when you increase the depth, you're able to see the node much more clearly, and you can see the needle and you can see the sheet here first on the left, on the right, and then you can see the needle then enter into the node from the right. As the needle tries to enter, you lose contact, and then suddenly you can see that the needle has down and pierced the node. You can see that the tip of the needle is actually through and through the vessel. Nothing happens here, even if it's through and through the vessel. And when you apply negative suction also, at the most, you might get some mild hemorrhagic aspirate, or you might try to do the aspirate without negative suction. Now, when you have a very small 4L node, this is where the problem happens. It becomes technically challenging. Here, you can see this is a zoomed out image, 2 centimeter, less than 2 centimeter. Node is around 1 centimeter, subcentimetric. Here, you can see this large vessel here. This is the aorta. And then you have the pulmonary artery here. And this is the node. So this node, I'm trying to pierce the node from keeping the sheath above the aorta. Now, this is a technique where you try to pierce that corner of the node so that you try to get the full length of the node, but you have to pierce just above the aorta to ensure that you don't enter into the aorta. So moving on to the third part of this talk, sonographic characteristics of mediastinal nodes. I think Dr. Yuvarajan has touched on this, where he said that sometimes the sonographic features helps us in taking a decision on what or how to proceed with this patient. This is an example of a patient who had a clinical diagnosis of hypersensitivity pneumonitis. She had parakeets at home, and she was presenting with shortness of breath and cough for almost a year. So this CT shows features suggestive of possibly hypersensitivity pneumonitis, but incidentally, there's a very large node, more than 2 centimeters. Any node more than 1 centimeter is significant, and that 2 centimeter node, single node. So this was subjected to an EBUS. And you can see that in the picture, you can see there's a small black spot inside the node, what we call as a hypoattenuation. And subsequently, the EBUS procedure was done, and you can see that there's a large white stental hilar structure seen inside the node, and you have well-defined margins. So this is an example of a benign node. So when we did EBUS TBNA for this and our pathologist reported this as reactive lymphadenitis, do we need to go further and take this as true negative, or is this a false negative? Again, as the honorable chairpersons in our earlier session has told us, in terms of malignancy, you have a lower negative predictive value, but when it comes to benign disease, especially when your sonographic features of benign disease are very characteristic, you can actually get away with just a simple EBUS TBNA and not push for further interventional procedures to sample these nodes. I have another 50-year-old male here who presented fever for 1 month. You can see large conclamation of lymph nodes. This is in the station 4L. When you see large nodes like this, you need to apply Doppler vascular to ensure that you're not looking at vessels. And you can see that the EBUS TBNA of this yield necrotizing epithelial cell granulomas, and gene expert showed MTB detector. This was an example of tuberculous conglomeration lymphadenopathy at the 4L station. And this is another example of a sonographic feature which can help us in telling us whether this node is pathological or not. You can see this intranodal vessel seen inside the node. And when applying color Doppler, you can see that the vessels are showing uptake. This is an example of a benign node. Actually, this was a non-necrotizing epithelial cell granuloma seen in a patient with sarcoidosis. And this is an example of a necrotic node. You can see a large black pockets within the node. This is known as the coagulation necrosis sign. This was seen in a subcranial node in a patient who was a 23-year-old female who was subsequently diagnosed with mediastinal nodal tuberculosis. Sonographic features have been described in detail. We had a publication in 2018 where we shared our examination of almost over 300 nodes, and we proposed that well-defined margins, presence of a central hilar structure, and presence of nodal conglomeration are predictive of benign disease. So if you see these type of features, you're more likely dealing with benign disease, and you may not have to push for further biopsies or even say mediastinoscopy even if you get a report which is say reactive lymphadenitis or possibly just lymphoid material. Further studies have come out from this. A lot of sonographic papers have been presented, and then you even have a systematic review and a meta-analysis which came out, I think, a year ago, which showed similar results. That if you want to rule out benign disease, these are the characteristics. But when it comes to malignancy, there were no specific sonographic features that they could propose. Now, coming to the learning curve, when you sample, what again our earlier speaker has said, you don't sample every node. You need to know what to sample. This is an example of a patient who presented to us in 2018. This was our first case of a bronchogenic cyst. He was a 44-year-old male who presented with non-productive cough and chest heaviness for around 7 months. You can see this hypoattenuated lesion which is sitting in the right paratracheal area. It has a Hounsfield unit of 0, so it's fluid in nature. It's the ideal site for a bronchogenic cyst. We went ahead and aspirated this. So you can see that there is a fluid level. I will show you that this is the SVC. Please remember that this is the SVC. And then you can see that this is the hypoechoic lesion. And you can see there are levels of fluid. The reason is because this hypoechoic lesion is having different densities within it. So therefore, you can start seeing different layers or levels. As the needle is puncturing through the hypoechoic area, you can see the tip of the needle has entered into the hypoechoic area here. And subsequently, we start, and you can see this needle here. Subsequently, we start aspirating. This double fluid level or the fluid level is clearly seen here, which is a characteristic feature of an anechoic or a hypoechoic lesion in the mediastinum. Subsequently, this is the video which is done in 2 times speed, where we are aspirating the fluid. You can see the this actually, both of them are fluid. This is a different density. You can see that this membranous type of fluid level difference, which you are seeing here, is slowly going up towards the surface as we are aspirating this fluid. We aspirated close to around 40 ml from this node or from this bronchogenic cyst. And as we keep aspirating, you can see that this lesion keeps coming all the way to the tip of the needle, beyond which we view the needle, we didn't aspirate the more density or more dense content which was inside the bronchogenesis. This is still fluid. This is the SVC. You can see that the SVC is opening. We published this in chest in 2019 from our department at SRMC. And this was a start of a series of cases that we started doing in SRMC, where we saw that any patient who had a bronchogenic cyst, we took up the patient for an EBUS procedure. This was based on papers and publications which were published in JOBIB. This was a single center study which said that bronchogenic cyst aspirating using EBUS was a good effort, but they said that only 5% of patients were actually having a long-term success. In other words, the remaining 95% had to undergo surgery. This is actually a very long follow-up. This was a single center experience from 2008 to 2020. Now, looking at a systematic review of case reports and publications, they said that the median duration of follow-up when it was around 1 year, there was no recurrence. Now, of course, bronchogenesis will recur after a year, so this may not be appropriate. But having said that, when you had an intent of a therapeutic TBNA and trying to aspirate the fluid, it was relatively successful, and the recurrence rate was not reported much. We subsequently saw much more bronchogenesis along the way in SRMC. We had multiple cases, we had done multiple aspirations, and it was always a pat on the back as we started aspirating more and more fluid, reducing the size of the cyst. But what was the long-term goal? These cysts were actually not getting cured, and they always had a chance of getting infected. They had a chance of long-term malignancy. So, and of course, we had to face one cyst, which would probably then make us sit and discuss whether we should actually go along with this way. This was a large cyst which came out in a female patient who was not fit for mediastinoscopy or even for a surgical procedure or excision, and she wanted remedial relief because she was having a dry cough. We went ahead and with EBUS thinking that this was going to be another another easy walk, but subsequently we found that this was a multiloculated bronchogenic cyst, showing us that bronchogenic cyst, even though multiloculated here in the scan, does not show, even though it was a plain or a non-contrast CT scan. The take-home lesson is you have a learning curve. What seems to be easy as you move along the way, we realize that sometimes things become a bit difficult to understand or comprehend that this may not be the way to approach these lesions. Another learning case, very similar to the case which was presented today morning, a 49-year-old male who was asymptomatic, took a chest X-ray for a routine job. We found to have this mediastinal lesion, and he has an old history of a thyroid removal for a large goiter. So we had this mediastinal lesion which is sitting on the left of the trachea. It could have been an ectopic thyroid, or it could have been some other tumor for that matter. And we went ahead with EBUS because it would be the only way to approach this lesion. So you can see that there's a big bulge here on the left trachea, on the left wall of the trachea. And keeping the EBUS scope on this lesion, you can see that we have an architecture which doesn't look like a lymph node. On the left-hand side, you can see that you just see a homogeneous image. And on the right-hand side, you can just see some whitish area surrounded by a slightly blacky area or a hypoechoic area. We put an EBUS needle through this. We got frank blood. And then we stopped the suction. We did it without suction. And again, we got frank blood. And we sent this for ROSE. We had a pathologist on site. And subsequently, what we did was we took the scope out and we put it into the into the esophagus to see whether we could get a better lineage or better image acquisition because of the collapsibility of the esophagus onto the scope, what we call as EUSB. And here you can see a classical image picture of a thyroid. So you can see this inside follicles with an outer cortex, just how a thyroid would look like if you did an ultrasound on the neck. So sometimes a learning curve is here when you are taking a sample from a lesion, when you don't know what you're looking at. Probably you need to know what are the sonographic features that will help you in picking up what you're looking at. The thing interesting here is we learn from here is that our pathologist was also not having an idea what to look at, and she gave a written report as possibly lymphoma. But subsequently, the final core biopsy came out as a thyroid tissue. So here, the learning thing is that when you're doing an EBUS TBNA procedure, we need to have a pretest probability of what we are dealing with so that we can correlate or we can correlate the sonographic features with the aspiration. And also we can also give this information or hand over this information to the pathologist who's there on site to at least have an idea of what to look for. Coming to ROSE, now rapid on-site examination of the slides on-site is a benefit for us. Not every center has it. I know many centers, even top centers who are doing EBUS procedures almost close to 100 per month are not having ROSE. They say they don't have manpower. And then you have pulmonologists who are doing ROSE, what we call as P-ROSE. But having said that, even though it's a benefit in our institution, we are having the advantage of having rows on site. Many a time we may not be able to get anything on site, and sometimes we need to wait for the blocks. But the rows helps in the sense that it helps to reduce the time of the duration of the procedure. It helps us to triage the samples. So, for example, if you've taken a pass, if you've taken the second pass, and your pathologist tells you that it's malignancy, you're not going to spend more time taking passes for, say, microbiology, or you're not going to take passes for cultures and so on. You're going to try to triage all the samples for malignancy. This is our publication again from SRMC, from the Department of Pathology in collaboration with the Department of Pulmonary Medicine, where they have looked at the last 100 cases where we have done rows, and the diagnostic yield was quite good in the first two passes, especially if the node was more than 2 centimeters. But I think we need to push harder and try to get a better diagnostic yield in smaller nodes. Important points when you're using rows is try to understand the feedback. Many pathologists do not realize that there are certain feedback codes. If they say that the aspirate is bloody, then you should actually stop the suction. If they say that you're seeing a lot of bronchial epithelial cells, then you should try to use the stylet much more effectively. Triaging of samples, I would like to have a short talk here. This is a case that taught us something important. This was way back in 2018, in the early part of EBUS in SRMC, where a 40-year-old female with fatigue, pancytopenia with splenomegaly, she had mediastinal and abdominal lymph nodes, and she had bilateral lung nodules. The lung nodules are very small, not clearly seen here. And the nodes are actually not also easily discernible because this is a non-contrast CT. On EBUS, you can see that these nodes are having intranodal vessels, and the aspirate was hemorrhagic. Now, when the pathologist asked me on table, what do you suspect? I said this could possibly be sarcoid. You have mediastinal nodes, you had lung nodules, there was a splenomegaly, there was a pancytopenia. It has been reported in sarcoid. It could be disseminated TB. And this is what I was looking at. And when the pathologist looked at the slides, she told me that it looks like a malignancy. She said that what we are seeing is large cells, and inside the cells, we are seeing large prominent nuclei. So this pushed us back thinking that, okay, then we probably have to triage more samples for core. So we sent more samples into formalin, into cytolite. And subsequently, final result was, it turned out to be a Rosai Dorfman disease. And what they were looking at was actually macrophages with emperipolysis. What these macrophages were doing was they were eating up the cells. And this is an example where there is a learning curve where the pathologist and the pulmonologist have to sit together to understand what we're looking for so that we can actually have a better idea. And it was after this that we decided that irrespective of what the rows or what the pretest probability was, we would always try samples in the sense that we would make sure that samples are sent for all possible investigations that we have in mind, irrespective of the rows outcomes. And this has proved along the way how we have moved forward. This is one of the recent cases that we have done. We had a patient with fever who had a large necrotic node in the left hilum. You can see this node showing PET uptake, and also having osteolytic lesions in the ribs, and also having some splenic lesions. This patient was having fever for 2 months with weight loss of around 10 kilos. His mother had active TB. His mother had active TB, and his sister had active TB. Both of them were on ATT at the 3rd month. This was straightforward tuberculosis. But we have gone along this learning curve such that we know that a differential diagnosis is for melioidosis. And therefore, when we did EBUS TBNA, we sent a sample for melioidosis, specifically for PCR for Burkholderia pseudomeli, and the PCR was positive. And we have even published this case in Curious. This was published only this year by a postgraduate in general medicine. So what I'm trying to say is that you would not be sending Burkholderia test in every EBUS sample, or you will not be sending Gene Expert in every EBUS sample. But what we need to know is how to improve your pre-test the probability of a diagnosis so that you can triage your samples much more appropriately. The recommendation by the EBUS TBNA guidelines from the Indian IAB Association as well as the ICS Association is that try to make sure that you send samples in cytolite and RPMI medium for malignancy. And if you're doing a sample because you're suspecting microbiological investigations, then appropriate microbiological samples. The question is, how do you balance sample adequacy with respect to triaging? Sometimes when you have a sample smeared onto the slide, do you think you want to push that for cytology or do you want to give that to microbiology? It's probably a decision by the clinician. Every clinician will have a different approach to that, but some studies have said that you should have a dedicated pass for microbiology. Last slides, cost effectiveness and complications. Again, we were talking about using multiple needles in patients. It might not be very cost effective, and we have this PGI paper that came out in Lung India in 2016 that actually created a big storm where they reused EBUS TBNA needles. It was actually a norm. Everyone was reusing EBUS TBNA needles again and again, but nobody was talking about it, nobody was publishing, or nobody was writing about it. This was a publication that came out, and they said that the yield was similar if you excluded granuloma. That means in terms of malignancy, you get the same yield. But if you're looking at granuloma, say, for example, sarcoid, the new needle gave you a better result than the old needle. But if you remove, because this was not a randomized study, this was a retrospective study. And if you remove all kinds of bias, they said the results were actually similar either way if you look at it. We reuse needles in SRMC. We use a 2.4% glutaraldehyde solution, and then we use ethylene oxide sterilization techniques. And the difficulties that we have faced with using these needles is that sometimes the sheet becomes too tight, the needle is difficult to pass, and sometimes we don't get adequate material. This happens, and the needle gets bent. The only complication we've got is the needle breaking during the procedure, and this was an EO needle. And this, what was initially supposed to be EBUS TBNA of a 4-hour node became a foreign body extraction procedure for the next 2 hours. So I could not bring this forward to Olympus because this is an EO needle. So in other words, we are trying to say that I'm doing a procedure with a product which was not meant to be used in that way. But having said that, this is something that we should understand because when you're using EO needles, the needles have a greater tendency to break. And last, additional flexible bronchoscopy post EBUS. This is also very important when you're doing EBUS procedures. Do not forget to do a white light bronchoscopy either before or after the procedure, especially if you're suspecting an endobronchial growth or when you're suspecting that you can get additional diagnostic yield from a bronchial biopsy or a transbronchial lung biopsy. And it's a simple example is this female patient who presented to us last year. Here you can see she's got nodal conglomeration in the subcarinal area, multiple nodes. You get EBUS TBNA from the nodes. The ROSE itself, on-site pathologist, within 15 to 20 minutes told us that it's a non-necrotizing epithelial cell granuloma. The serum ACE was 140. It's straightforward sarcoid. But still, we went ahead with white light bronchoscopy. You can see this subtle endobronchial nodularity here in the airways, and biopsies from the mucosa also showed non-necrotizing epithelial cell granulomas, clinching a diagnosis of sarcoid without any reasonable doubt. So summarizing, in terms of sedation, you can tweak your sedation protocols in your EBUS procedures, but the take-home message is you should give fentanyl plus midazolam because one is for sedation and the other one is for analgesia. And now the newer trend is to give cricothyroid injection plus lignocaine spray as you go. Nebulization has moved out. Difficult nodes, remember the easiest nodes to start with is start with 7, start with 4R and 11L. As you move, the difficult nodes will be 11R and 4L, where you might have to puncture without seeing the node and where you might have actually a higher chance of getting a bleeding aspirate. Never think aspiration alone is enough. Try to look at the sonographic characteristics of the nodes because they may help you in deciding whether you want to do a further next procedure when you don't get an adequate or a diagnostic sample. ROSE, it helps in reducing the procedural time. It allows you to triage your samples because then if you know it's a malignancy, you will send the remaining samples in formalin, but it does not increase the diagnostic yield. The diagnostic yield is actually dependent on the size of the node and it also depends on the procedural technique. And always be methodical. Scan all stations and make sure that you take 3 passes from each station. But now newer guidelines have said that you can take at least 2 passes from each station and at least sample 3 nodes. Always add a white light bronchoscopy if you're suspecting sarcoid, do a bronchial biopsy or transbronchial lung biopsy. If you're suspecting an endobronchial tumor, do white light bronchoscopy and take endobronchial biopsy. The learning curve doesn't stop, even for me. I've not done transvascular access like Dr. Yuvarajan sir was discussing. I've not done intranodal forceps biopsy or intranodal cryobiopsy. These are things that probably I'll be looking forward to. But having said that, the learning curve never stops for anyone who does EBUS. So as you go along the way, you need to learn and you need to fine-tune the skills so to get a better diagnostic yield and have a better clinical outcome. Thank you.
Thank you, Dr. Irfan. For want of time, we'll keep the questions short. Any questions from the audience?
Regarding the puncturing the vessels, you puncture the atherosclerotic aorta or calcified aorta.
Yeah.
Regarding puncturing the vessels, if you puncture the calcified aorta or atherosclerotic aorta, the risk is more. And also puncturing the pulmonary vein. If you have 2 or 3 passes may tear the pulmonary vein, the bleeding will be more.
Yes, sir.
One more thing you pointed out is reusing the needle. The chance of breaking is more.
Yes,
This is a very good valid point. And one more question I want to ask is, if you are taking a EBUS sample from a large necrotic node, we are aspirating, flooding with AFB. How will you prevent the further leakage from the node to the mediastinum?
So
There's a risk is there, no? You are tearing the capsule. The pus may leak from the mediastinum. It may cause mediastinitis.
yes,
How will you prevent?
we can't prevent, sir. Actually, in fact, this is a I think this is one of your own patients.
Yeah, this is a experience.
This is a female patient who was
Yeah.
we even subsequently she developed a
Pericarditis, yes, sir.
pericarditis.
How to prevent, sir?
If it's a very large necrotic core, it cannot be prevented, sir. So it can track. It will find the easiest way to track and it will
Yeah.
track out.
Thank you.
Thank you, sir.
And Dr. Irfan, your experience with reusing the needles. How many times do you usually reuse the needles? Because previously, when we used to start the EBNA, blind EBNA, I used the needles at least for 7 to 10 times previously. I think the needles which come now don't last that long. Your experience on that?
We don't use it for more than 2 times. That means if you use it for the first time, that's new. And then when you are using it reusable, we use it as 1 and 2. So that means that the maximum a needle can be used 3 times. If it's a node which was malignant, we don't reuse it at all. If the node was granulomatous, we categorize that needle as reusable, send it for glutathione solution, ethylene oxide, bring it back. And then the first time we reuse it will be reuse 1.
Thank you. We had a wonderful discussion on EBUS. Thank you, Professor. May I request Professor Chandrasekhar sir, our President of Association Pulmonology of Tamil Nadu, please give the memento to our chairperson and our guest, our speaker. Come on. Memento to Professor Irfan. Thank you. Wonderful. Crisp and clarity. Very nice. Memento to Dr. Anbumaran, Harish, and Jackie Moses. Harish. Dr. Jackie. Thank you. We had a wonderful session. So, any quiz? Yeah. Deepika will take over for the quiz. Yeah.
Thank you, Irfan sir. That was an amazing talk over there. It was filled with clinically clinching points. Always a pleasure listening to you, sir. Thank you. We shall have some rapid fire quiz rounds right now for the PGs and for the faculty.
Yeah.
All right, this question was already done last time. The fourth question, which specific brainwave pattern dominates the electroencephalogram during a non-REM stage 3 sleep? You've already answered, right? Both of you have answered. He hasn't. All right, yeah. Good job. All right, congrats. He gets it.
Okay, do the IMA break. This is simple.
Moving on to the next question. Which rare sleep disorder is characterized by a sudden and irresistible urge to sleep, often leading to unplanned and abrupt episodes of deep sleep throughout the day? No, ma'am, not you. Any takers? If the PGs are unable to attempt this, I shall move the question over to the faculties. Open to faculties as well. Ma'am, not you, ma'am. Any takers? Ma'am says B. I'm sorry, ma'am, it's not B. One more. Ma'am. All right, fine, okay, I give it to Shivani, ma'am.
Sorry for the prize. It is A. Klein-Levin syndrome.
But you do get a prize. And a prize, ma'am. Yes, yes. Yeah. All right, one more question for the PGs. Which cytokine is more central to the fibrotic process in IPF and has been a target for recent therapeutic developments? Anyone to take it? Yes. We have someone there. You haven't already answered, have you? All right. Good job. You can give it to him.
Yeah. Introduce yourself.
I'm Gokul from MMC.
Thank you.
Good job, Gokul.
Gokul, congratulations.
All right, we shall move on to our next topic for the day. I shall invite our chairpersons, Dr. Irfan sir, professor at Sri Ramachandra Medical College, to chair the session. Irfan sir.
Professor Irfan. Okay. Irfan.
Dr. Yuvarajan sir, professor and head at Sri Manakula Vinayaka, Pondicherry. Yuvarajan sir.
Dr. Yuvarajan. Yeah.
Sir is not.
Okay.
Um, all right. I request. Yes, Yuvarajan sir.
Yuvarajan.
I request.
Kaushik is there. Kaushik.
Yes. Oh, yeah.
Kaushik, please chair the
I
session.
request Dr. Kaushik to also join us to chair the session. Our next speaker is a very young and dynamic interventional pulmonologist at Adyar Cancer Institute. He has recently added a feather to his cap by completing 100 EBUS procedures over the last 2 years by himself. I welcome Dr. Tyagesh to take over the stage.
So, Dr. Tyagesh, I think he doesn't need any introduction, especially in Chennai. One of the person who is doing, is taking intervention, is trying to taking interventional pulmonology to a different level in Chennai. And he's one person who did the highest number of metallic stents. I think everybody will accept this because he's a center where you get a lot of referrals for metallic stents. And I have discussed just now, what is the, the follow-up of the, different patients who received metallic stents. And he completed fellowship in interventional pulmonology with my friend, Dr. Hari Kishan. Faculty in various national and international conference, member and life member in different respiratory and thoracic societies. He is going to discuss regarding radial probe EBUS. It's a bullseye view. Yes, Tyagesh, over to you.
Thank you for the kind introduction. And I would like to thank the MGM team for giving me the chance to present here. In today's presentation, we will discuss about the technical aspect of how radial EBUS is done. And radial EBUS is the first to be invented before our conventional EBUS in 1980s. After inventing the radial EBUS, then the concept of conventional EBUS has come. So for the introduction, the bronchoscopy has been used worldwide for the diagnosis of pulmonary nodules and centrally located mass. And the radial EBUS has emerged as widely accepted procedure that can increase the sensitivity and accuracy of diagnosis of a peripheral pulmonary nodule. The radial probe can be precisely locate the pulmonary nodular masses based on difference in echogenicity between the normal lung parenchyma and the lesion itself. So unlike conventional EBUS, radial EBUS is it is just a flexible catheter or a probe which pass through our normal bronchoscope working channel, and it has a mechanically rotating tip which rotates at 400 rotation per minute, and it gives a 360-degree image in the image for us. So this is the difference between the radial EBUS and the conventional EBUS. If you see in the image one, this is your conventional EBUS. Conventional EBUS has a bronchoscope with an ultrasound probe at the tip of the scope, and radial EBUS is just an ultrasound probe which passes through a regular working channel. And the frequency of a radial probe goes to 20 millihertz, and for a conventional EBUS it is 5 to 12. And with a conventional EBUS, you get an angle of 60-degree view of the mediastinal nodes. But if you go to the radial EBUS, we get a 360-degree view like this. So where can we use this radial EBUS? So if you get a lesion like this in a CT, this is what we call as a peripheral pulmonary nodules, where there is no bronchus leading to the lesion, or the lesion is not close to any trachea or a main bronchus. So these kind of cases where we will be using a radial probe. And when you pass the radial probe into the lesion, you will get an image like this. You can see a mouse pointer over here. So the central tip is the radial probe, which is seen in the ultrasound view, and you get a 360-degree surrounding view like this for locating the lesion. in our day-to-day practice, we used to get a lot of nodules like this. So any nodule of size up to 8 mm can be sampled with the help of this radial probe. We'll go to the equipments. There are two companies which are giving this radial probes. One is an Olympus and a Fujifilm. So it both has a similar characteristic features, like the outer diameter will be like up to 17 mm, that is 1.7 centimeters, and length is around 115 centimeter, and it has a frequency of 20 millihertz, and it rotates at 400 rotation per minute. The scanning view is 360 degree, and the depth of penetration will be 4 to 5 centimeters. So this is the rotating tip of our uh, radial probe. You can see the tip which is rotating over here. When you pass this rotating ultrasound tip into your bronchoscope, and when it hits the lesion, it gives a 360-degree scanning view of the probe. And there are certain things equipments which we use before going ahead with an EBUS. So first is your guide sheath. The first image which I'm showing here. So the guide sheath has a inner diameter of 20 mm. So there are multiple sizes of bronchoscopes available with us with the different working channels in our bronchoscope. So commonly the scope what we use has a working channel diameter of around 2.8 mm. So when you want to use a guide sheet, it is better to go ahead for an adult bronchoscope to use it. And if we have the luxury of having our smaller bronchoscopes or a pediatric or ultra thin, we can do the procedure without guide sheet. So these three equipments which we commonly use. So the guide sheet which has a diameter of around 20 mm. On the forceps which we use for a radial lever procedure, there are two sizes available, that is which is 1.2 mm and 1.4 mm, and the brush which comes around 1.4 mm diameter. And this device is called as a curette device. So when we go out for chasing this peripheral pulmonary nodules, we'll be going to multiple generations of bronchus, like third or fourth generation bronchus, where there will be a lot of angulations will be happening inside the airways. To guide the guide sheet into that particular angle, we use this curette device. So this will help us to guide the guide sheet into the particular bronchus where we are going to trace it. So this is a probe driving unit. So radial EBUS comes with a probe driving unit. We'll be connecting the probe. We can see that connection over here. And this is an Olympus probe driving unit, and this is a Fujifilm driving unit. So these are the basic equipments which we need for setting up a radial EBUS procedure. The next step in going ahead to the radial EBUS procedure is to locate the lesion. So which lesion we are going to target. And CT chest, like our HRCT, plays a major role in making that call. Whenever we see a CT, we should see the CT in all the three segments, like both axial cuts, coronal cuts, and the sagittal cuts, to know the size of the lesion, location, relation to the vessels, and whether relation to the bronchus also. So all these things will be assessed with the help of the CT. So whenever we are planning for a radial EBUS, CT is a first step in going ahead with the radial EBUS. And the next one, what we have to focus mainly is your bronchus sign. Whether there is any bronchus which is directly leading into the lesion like this. If you see this images, you can see there is a branches of bronchus which is coming directly leading into the tumor. So whenever you have a bronchus sign positive, and you will get a concentric image in the radial probe like this. So the radial EBUS, there are four factors which impact the diagnostic yield: the size of the peripheral pulmonary lesion, nature of the lesion, and presence of a CT bronchus sign, and position of the EBUS in relation to the lesion. So whenever the size is more than 2 centimeter, we get a diagnostic yield of around 80 to 85%. And if its size is less than 2 centimeters, we get a diagnostic yield of around 60 to 70%. And whether nature of the lesion, whether it is a benign or malignant, and presence of a bronchus sign, and the position of the radial probe to the lesion. Around 51.6% of lung dialysis do not have a CT bronchus sign in our routine practice. So if there is no bronchus sign positive, and if the bronchus is going adjacent to the lesion, we get an eccentric image like this in a radial probe EBUS. So these are the A, B, and C are the common images which we will see when there is a bronchus sign positive. When the probe can be passed into the lesion, you get a concentric image like this. When the probe is when the lesion is very adjacent to the bronchus, it is not communicating with the bronchus, then you get an eccentric image like this. And this is what we call as a snowstorm appearance. This is a normal lung parenchyma will be seen like this in your radial probe EBUS. So these are basic anatomy where there are four types of bronchus and tumor relations which we will be seeing. In the type 1, that bronchus will be directly leading to the tumor. In type 2 is the bronchus will be going through and through the lesion. And type 3 is the tumor will be adjacent to the bronchus, and type 4 is there will be a proximal narrowing just before the lesion so that we won't be able to approach the nodule. So all these things has to be assessed when we are performing a radial EBUS procedure. Bronchus sign is like this. When you are able to pass the probe directly to the tumor positive, then it is a bronchus sign. And if the uh, tumor is adjacent to the bronchus, then what you are getting is a negative bronchus sign or a non-bronchus sign. And for target localization, uh, we follow this bronchial branch tracing technique. So as you all know, we are targeting a very small nodules, like nodule size of less than 2 mm or 3 mm or 4 mm. So to know that to which bronchus to take or which division to go into the airway, we usually follow this technique. Actually, bronchial branch tracing itself is a large topic to discuss. So I'll just keep it short in this. So imagine we are going to target a left upper lobe lesion. So when you go into when you pass your bronchoscope into the airway, the first image, this is the image you will be getting in the airway. So you get a lingular segments over here. You have an apicoposterior segment over here. So we will make a chart or diagram when we are planning to approach the case. So first we'll be drawing the circle, which having a lingular segments and the apicoposterior segment of the upper lobe. So our decide segment is the one which marked in the X sign. So once you go into the upper lobe apicoposterior segment, then you have two more segments like this. So you will be you will be drawing a diagram like this, like one in the up and one in the below. And our decide segment will be marked as an X over here. Then if you go uh, further deep into the bronchus, that's when you go to your third generation bronchus, you'll be having further two segments. So this will be your left main bronchus. Then this is your apicoposterior segment. Then into the apicoposterior segment, you have two segments. Then into that lower segment, if you're going, you will be marking it as an X over here. So then if you pass into that segment, you will be hitting over the nodule like this. So even though there are a lot of newer technique like navigation bronchoscopies or robotic bronchoscopies are there, but we don't have the luxury of having all those techniques with us to locate the smaller nodules. So these are these things which we can do. Like I hope everyone will be having an IPAX in your systems if you work in an institute. So we can do this planning in our OP table itself, like which segment or which pathway has to be followed to reach the nodule. So there are certain techniques for each and every segments like this to go ahead. So that's what we call it as bronchial branch tracing. And whenever we document a nodule, we'll be documenting as LB1+2. That is your apicoposterior segment. And into that, we'll be going to, there are two segments, A and B. We'll go to the B. Then the further subsegment will be marked as Roman letter 2. So it is LB1+2 and B2. So this is the segment where this nodule will be there. And this is a Japanese style, like Dr. Korimoto's technique of bronchial branch tracing. I hope you can all Google this thing. And there is a book also written by Dr. Korimoto. So this is how the target localization will be done. For assembling the radial EBUS, I'll just show you a small video how we do in our center. We have a Fujifilm system. So this is your radial EBUS processor. First, we will be connecting the radial EBUS processor. And that's your ultrasound radial EBUS processor. And this is the Fujifilm monitor for your bronchoscopy. So this is the probe driving unit, which you are seeing over here. And in the monitor which you're seeing, you are getting two images. The bigger one is your ultrasound image, and the smaller one is your endoscopic image. So hardly take 40 to 50 seconds for us to assemble that setup, and you get a rotating tip of the radial probe over here. And these are the common equipments which we need. So this is your probe driving unit. This is your cryo probe and your brush, cytology brush, and we have a forceps and your radial probe over here. So these are the basic equipments we'll be needing to go ahead with the radial probe EBUS. And you get these three appearances. The first is your normal lung parenchyma. And when you get a ground glass opacity rather than a mass or something, we'll be having a blizzard sign. So you can see that whitish appearance over here has been extended to further more deep. So this is how a blizzard sign will be. And when you have a benign lesion, you have a mixed blizzard sign lesion. So when you have both, it's a subsolid lesions. When you have both a solid component and a ground glass component, you'll be getting this thing. And certain things which we'll be noting in our radial EBUS procedures will be the center tip is your radial probe, and this is your lesion. And we can also document whether the lesion is having any calcification, bleeding point, relation to the bronchus, or a presence of any multiple cyst or dilated bronchus. All those things can be diagnosed with the help of a radial probe. And to document all those things are very important, because if you have a a blood vessel running into the mass lesion, and you can't use a cryo probe into the lesion to take the biopsy, because whenever we use a cryo, the bleeding will be more in those scenarios. So all these things has to be seen in a radial image, and there are four. These are the 6 types of images which we get. The first one will be is your homogeneous image. Type 1 is a homogeneous image with presence of vessels in between, and type 2 is a pure homogeneous. So this type 1 image will be more of a malignant pathology if you get this kind of lesion. And type 3 will be your heterogeneous lesion with presence of some calcific specks and vessels. So these kind will be more of a benign etiology in radial probebusis. So procedure, there are two ways to do a radial procedure. One is your guide sheath technique and a non-guide sheath technique. For the beginner perspective, I focus more on your guide sheath technique, how to go about. So first we have to assemble the guide sheet. So you have to pass the radial probe into the guide sheet like this. So I use an airbag guide sheet which comes for a cryo probe, but you can use an Olympus guide sheet also. The name of the guide sheet is Olympus SG200. So once you pass the cryo probe into the guide sheet, you'll be seeing the tip of the rotating probe comes over there. You should pass only up to at this level, where you can see the rotating tip just outside the guide sheet. So once this assembly is done, then we will take these guide sheet along with the radial probe and we will pass it into our bronchoscope. So as I told, the radial probe is just a probe which goes into that working channel of a bronchoscope. We can do with our adult and the pediatric scope also. So just for a learning aspect, I just place a stopper over here to consider that as a lesion in your bronchoscope image. So you can see the guide sheet coming out of the working channel, and it's always mandatory. Like there are So this technique is very useful if you don't have a voice ability. If you have a voice ability, then it's more art advantage. You can go, but you cannot push the really in the spelling, so if you marking the text in the text microphone, then you pass this microphone into your class. Coming up from the text into there. Same for the process also, the measurement is same, but one important thing in the process is, so this is the amount of process has to come out of the just the metallic part of the process has to be the same. So you have to measure at this level. And this is an animated video of how radial is done. So when you use an ardent bronchoscope, you can, I mean, if you have a bronch or a webcam will go to this level, then your radial used for scanning the airways like this. So you are able to find this particular tumor, the particular level, then so this is the guide sheet which you're seeing the metallic crown. So that's a radio frequency. Then the guide sheet will be placed there, and whatever equipments you want, like brushing, then when you can pass the hose or sounds. Most of the centers will have the facility of having rapid on-site evaluation. We will be doing imaging cytology with brushing samples what we are getting, so that we will know which what sample they need and whether to take the sample for any gene expert or further analysis can be done with the help of. So, so the case where we have done a radial investigation for a lesion in the left upper lobe. You can see there is a lesion which is noted in the left upper lobe. And Why is radiating risk than the conventional CTs? We do have very low risk of getting pneumothorax and other complication compared to that. And whenever we are targeting a lesion like this, it comes for malignancy, we can do a staging also in the same setting. So it is like diagnosis, staging can be in the same setting for patient. So whenever the folk is the lesion will be getting a hypothesis that is excellent stage, where the lesion is there in the only one part of the lesion. Once the lesion is globalized, we will keep in the guide sheet inside the data. So this is your guide sheet which is here. The guide sheet will be placed at the same place, and you can see this radio guide sheet distribution. Then the equipment will be passed into the lesion over here. So if you have a fluoroscopy, you can know which place you are targeting on. You can pass clean air forces so that sort of cryoprobe in the lesion going into the process. And one advantage with this guide sheet, the latest one which I'm using with this guide sheet is so whatever guide sheet comes with 1.7 mm diameter, but this one comes with 2 mm diameter. So even the 1.1 cryoprobe which we are using inside, initially it takes end block. Like if you are placing the cryo, you have to take the entire equipment outside, then you will go. But with this guide sheet, it's just clearly and take the cryoprobe. That's the new advantage. It comes with an 1.1 mm. So the next case is a 50-year-old female, small student, present with cough and frustrating hemoptysis, present in the middle of speculated with a fluid tag like this. So this case we did without patient. So whenever we have a spot of bronchoscope like 3 mm or 5 mm, we can directly go to the second half representation bronchus. We can see the lesion as soon as possible. Sometimes if there is any family, then we pass the area go into the box and you get concentrate image. It's homogeneous concentrate image and it mostly comes from malignant lesions. Parking that lesion they have of course. So 1.7 mm diameter which we use for the procedure. Take biopsy from the lesion. And diagnostic increase up to 80% when the probe can be positioned centrally within the lesion rather than adjacent to the lesion with only 40, comes to 40 or 60. The ability to achieve a concentrate view was not statistically significant, but the technique using guide sheets and the directional pivot combined with the small collision rounds. A detection rate of concentration of around 81.6% in the radial test. When you use the fluoroscopy, in the study, then the visualization of lesion was in 82.3%. And the overall diagnostic yield was 72.5%. And the diagnostic yield was 64% for a very good lesion of size less than 20, and it's 80% for if the lesion is more than 20. The limitation is whenever we use a radial probe, it is not a real-time image guided biopsy, unlike the conventional images. Conventional images we will be seeing how the lesion entering into the nose or but here it is it is used for the localization purpose. And even with the use of guide sheet to direct the sample abstain lesion, there's a chance that the guide sheet position can change. We just like move our hand or every. So there are certain techniques to navigate this technical difficulty. So that's they have this navigation also. So if you have a very good lesion like subpleural lesion like this or a very smaller lesion in the left upper lobe. So what we will use is a navigation bronchoscopy technique. So there's a separate navigation protocol which will get so later this table just copy the image in this navigation protocol in the CD. Then we will be uploading it in the navigation machine. It's the like bronchus, they have a lung point machine. So once we load the CD in that, then it will give us a like same how like Google Maps give us a way to reach the nation. So the navigation bronchoscopy will give us a like if you follow this line, so which side to be taken? If you got to go to the left side, then inside the left side you want to go to the left upper then these subsegments to be taken how to reach the target. So this will give us an exact idea like how to go and reach the target. But still we didn't have a drawback that the real-time imaging is not possible in this scenario. So in those kind of scenarios, we will be using a phone beam CT. Phone beam CT where it is like wherever there is a cath lab, you can just upload the phone beam CT software and you can use it for our purposes. So phone beam CT, this is like a spin will be produced by the machine. The patient will be lying there. So one full spin of the patient will be getting that CT image of the lesion in the real time. So we see the image one. You see this is the bronchoscope which is going, and you can see the probe which is located inside the lesion. So this is a two-dimensional image. But with the help of home beam CT, if you make a rotation, you only see both the lesion and the probe are there in different places. So these kind of technical challenges can be handled with home beam CT. Like you know whether they're really through the lesion or they are just in front or behind the lesion. And if you see in the second image, when all these muscles will be damaged, okay, so the respiratory movements given by the anesthetic and measure generating movements, how the respiratory movement is varying the probe of location in particular lesions. So whenever we have this kind of respiratory movement happening, we will ask our anesthetist to give an empty time for us to go over the procedure. So all these smaller minor technical details can be handled. And this is only CT guided biopsy case. You got a right upper lesion. So the steps will be like same about radial investing what we discussed now. We will put our radial probe into the lesion. We will target this lesion. We will identify where is the lesion over there. Once probe is the lesion, you will be seeing a constant images. Then you know your probe is exactly in the lesion. Once the recommendation is imaging to see whether we are really into the future. Then case create the type of original bronchoscope, so when we are expecting now that's a white mark which is seen. So you can confirm the biopsy is exactly there inside the lesion. So this is advantage with the bone beam CT, where the lung biopsies. The next comes the robotic bronchoscope. It is not FDA approved in our country yet. Hopefully by 2026 we will be getting this. When we spoke with the company people, they were targeting India for 2026. There are three brands available: Monarch, Ion, Intuitive, and Galaxy. And robotics will be like same like whoever plays game or not, it will be very easy for them. So you have to place your robotic bronchoscope. Then it's kind of a joystick hand operated movements only. You can just drive the scope into the hand. So these are used for very smaller norms. And nowadays, the latest research is happening in in Hong Kong. What they are doing is they are making a diagnosis, then staging, then micro ablation of tumor also done in the same city. So we have a bronchoscope with precise to locate the lesion. We can just ablate the tumor, like both the diagnostic and therapeutic things are happening in the same bronchoscope units. So that is how technology is developing or being. So with this thing, robotic like just moving with the hand operated buttons to reach the target. So we can see this in this like how the controller is happening. Dr. Carrot from Hong Kong, I think he's doing this study in micro. This comes with it. All the animation and everything taking care of it is robotic. You see, the lesion is there in parallel to the lung. It is not at the center of the focus. The image over here is tells us the relation of the needle to the tumor. So we can precisely locate it and do the marking. And the complication, the rate of pneumothorax after intubated transbronchial force of biopsies are reported around 0 to 0.5%. And a bilateral quoted pneumothorax is around nearly 5% after transbronchial biopsies with a cryoprobe in interstitial analysis. And someone is very good conversation present challenges to knowing relatively where to take biopsy. And radiography provides a procedural feedback regarding the location of the target lesion. And use of cryoprobe for obtaining biopsies from peripheral lung lesion is feasible. One thing what we want to say is that a physical thing. It doesn't mean that we have to use a cryo. Whenever we have a process, we do the process biopsies. In comparison to the process biopsy, significantly larger samples can be obtained without affecting the safety. And data from very cryo biopsy without taking after profit. Thank you. First, we can take one question, sir. Further, we discuss during the tea time or eventually.
Thank you, Jagesh. It was a very wonderful, exhaustive presentation on how to approach peripheral nodules. So my question to you would be like whenever they have a concentric lesion. So what is your experience while using a forceps biopsy versus cryo biopsy? So is cryo mandatory for a concentric lesion, there is any increased yield with cryo in concentric lesions. Of course, there will be increased yield in eccentric, but concentric, what is your take? The concentric lesion, they are not cryo. The force of cryo is inadequate because we know the force of catching the tumor and even the long into the tumor. Cryo has an advantage in the eccentric lesion, but when you have a tool with you, like cryo, so you should take almost concentric lesion also. And one thing is that sure, so observe and use the cryo that most okay, yeah, that's the point I wanted to make. Even if it is a constant rate, if the pathologists are planning to do IHC and everything, will that be a good sample for pathological examination, or cryo sample will be much first? Like we can cryo, get more passes from cryo biopsy to give a sufficient sample to provide an H. But with both of we may have to be biopsies. Then the chance of new subtracts is also there. The more if we go beyond the field.
When the lesion is so much peripheral, smaller lesions, when you use ultraviolet scope and given forces for the force size will be also very small. Right? So once you take that so close to the pleural at all, you have to take multiple bits to get that diagnosis. In that case, I think will be much helpful. That is the thing. And from that, say one final comment from this. As you are telling that real-time imaging is not possible, like meridian probe. So to increase the confidence, we use other modalities to see that whether our target is achieved or not. So if your scope is coming in future, like linear EBUS, if you have a small ultraviolet scope with a probe attached to the distal, then we can trace that, to the branch segment up to the end. What is your opinion on this?
Well, like when you add an extra component diameter of the scope changes the so that's why we are releasing the picture. So what's what it is? You have a CF for all those CS not they use that for scoping. It's different component. And definitely like as the technology comes like that, then it's really like single equipment can solve all the subjects.
Thank you, thanks for that.
Thank you. My interest Dr. Kasi sir, please come and give the motto to our chairperson and the speaker. For the speaker, I say that. Roger. Thank you. We'll move on to the inaugural session. We'll move on to the inaugural session. May I request our chief guest of the day, Dr. Swami, Senior Consultant, Director, Respiratory Medicine and Sleep Medicine from Narayana Healthcare Hospital Project. Welcome, ma'am. May I request a guest of honor, Professor Dr. C. Chandrasekhar, the President of the Association of Pulmonologists of Tamil Nadu, and Professor HOD in the ACS Medical College. Welcome, sir. May I invite the Indian Medical Association, South Zone Vice President, Dr. S. Kazi, sir. Sorry, North Zone. North Zone Vice President, Kazi, sir. Please welcome the diary. May I request our CME observer from Tamil Medical Council, Professor Dr. Raghunandan, sir. Please welcome. Please take a seat. May I request our Director of Medical Service, please give the floor quickly to our speakers and guests. Floor quickly to our DMS to assist guests, Dr. Swami. Please welcome to Professor Chandrasekhar, sir. To yes, Kasi sir, Vice President of Narju. Now, quickly through our senior observer of DNMC, Professor Raghunandan, sir.
We'll move on to the ceremonial invocation, lighting up the Tulku. May I request Sheila ma'am, please play the invocation songs, and I request chief guest and our women in pulmonology, Dr. Telugu ma'am, Gayatri ma'am, Gayatri, you have to pray. Let's start with prayer. Okay. So first we'll start the IMA prayer by Dr. Gayatri.
IMA prayer. May everyone give a
Rise for that.
May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and will. Physician prayer. Dear Lord, the great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray. Give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to live, at least a part of the burden of my suffering fellow men, and the true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee.
Thank you, ma'am. Very good. Let's move prayer for the IMA prayer.
Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift comes from thee, I pray, give skill to my hands, clear my vision to my mind.
Performance group, Dr. Telugu ma'am, Gayatri ma'am, and Srini ma'am, please come for the lighting with Telugu. Candle, please, the candle. We'll have a brief group photo of the guest and chief guest and all. Next, we move on to the unveiling of the CSM name board, that is Southeast Asian Academy of Sleep Medicine name board enabling by our chief guest, Dr. Shivani Swami. Shivani Swami is one of the national authority in sleep medicine. Madam is the CSM secretary, and he is having various posts in Chess Council of India leader, and he is recently elected governing body member in in the society. I request to unveil the name board of Southeast Asian Academy of Sleep Medicine. Yes. May I request our chief guest for the inaugural and the chief guest address.
Everybody, as always, it's a great pleasure to be in Chennai under the auspicious company, and thanks to Chairman Sir, he's always very active. So, just a few words about CSM. It is the Southeast Asian Academy of Sleep Medicine, which was founded in 2015. It was founded by just a handful of people who wanted to increase awareness about sleep disorders, not only amongst doctors but also about general public. Over the years, we've done several conferences. We did 5 international conferences, the last of which was pre-COVID in Nagpur, and for hundreds of thousands of doctors in our humble endeavor to include people, to increase awareness, and then COVID hit us and everything did come to a standstill. Sleep practice per se was something which was extremely affected because people did not want to come to the hospital. And then, of course, nobody wanted somebody else to be coming to the test or anything at all. So, sleep medicine was something which was extremely affected. However, post COVID, we have now taken the re-initiation of the conference, and we shall be in the 6th International Conference on Sleep Disorders in Indore, to the 5th and the 6th of October. And I'm very happy to say that we actually have a great enthusiasm and involvement for the Tamil Nadu chapter, all thanks to Sir's leadership. So I look forward to seeing you all at Indore in our humble endeavor to reinitiate the conference momentum. And with that, I'll hand it over to Sir. Thank you very much.
Thank you, ma'am, for this wonderful initiative of Tamil Nadu chapter of CSM. We do all the good promotional activity for the students awareness for among ourselves and then the public. So thank you very much. Now we'll have a short tea break for 10 to 15 minutes. I request everyone kindly again release 10 minutes time. So we'll have a 10-minute speaker. There is a 2 keynote session on TV and keynote session on the sleep and all. May I request the time for the tea break and welcome to join again after 10 minutes. Thank you.
Wait. 1,55,650 people were relegated on DRTV in 2022, which means 22 out of 5 eligible DRTV patients and put on the micro shrinking on TV lower margin in 2023 as follows. The TV patient coverage at least 90% by 2027. Coverage treatment between 90% by 2027. And the coverage of RAPS diagnostic testing for TB should be 100% by 2027. If you see the recorded cases of DRTB put on treatment between 2015 and 2022, the graph shows a downward decline. This seems to be encouraging, but at the same time, it is not real in the sense lot more cases of DRTB are yet to be diagnosed. As I told you earlier in the previous slide, 2 out of 5 only are diagnosed. So it is for us to suspect possibility of drug resistance in each and every case of TB diagnosed, exclude that and give appropriate treatment to tackle this problem. And if you see the prevalence of rifampicin resistance TB among the new cases, in 2015 it was recorded as 4% among the newly diagnosed cases. In 2022 it was 3.4 and 2022 it is 3.3. Among the previously treated, the same figures goes very much higher. It is 25% in 2015, 20% in 2020 and 17% in 2022. This downward trend gives a sense of satisfaction in the sense that we are using upfront molecular diagnostic tests to pick up resistance. So the number of resistant population is getting reduced in the society. That's what we presume. But at the same time, there is a large gap between the estimated cases and detected cases and put on treatment. 3 countries accounted for 42% of the estimated global number of people who developed MDR or RRTB in 2022. India leads with 27%, Philippines 7.5%, and the Russian Federation 7.5%. I told you earlier that among previously treated, the percentage of MDR or RRTB can be 17% globally. But in Russian Federation, if you see, the prevalence of rifampicin resistance or MDR TB is to the tune of more than 50%, which is a cause for alarm as far as Russian Federation is concerned. If you see the global targets, which was set for 2018 to 22 over a period of 5 years, the target of detection for drug-resistant TB detection was 1.5 million or 15 lakhs. Whereas in the same period, we have put on treatment 8,25,000 means, which means only a 55% coverage. Similarly, among the children, more than 1,15,000 cases should have been detected and put on treatment, whereas we have put on treatment only 21,600, which is a meager percentage of 19%, which shows there is a large gap between the estimated number of cases and the cases diagnosed and put on treatment. On the other side, if you compare the cure rate, the DSTB is hovering around 85% between 2012 to 2021. Not much improvement has happened between 2012 to 2021, despite the fact that we are able to use upfront molecular diagnostic tests. We should do something for a more successful, shorter, relapse-free curing regimen for the DSTB. That is the need of the hour. At the same time, if you see the graph that is giving the cure rate for the drug-resistant TB, that is promising. Between 2012 to 2021, way back from 50%, it is reaching beyond 65% now. 2016, we got the Bedaquiline inaugurated as a conditional access program in the country, and ever since globally, Bedaquiline is giving significant cure rate. Currently, with the shorter regimens, all oral shorter regimens as well as all oral longer regimens, the cure rate is 70 to 90%. So this is a global scenario. Let us see what India has done towards this drug-resistant TB. What are the steps taken by our government? To assess the problem in the nation,
the India conducted the first national anti-tuberculosis drug resistance survey between 2014 and 16. Till date, this is the largest drug resistance survey anywhere to be done in the globe. And these are the main points which came out of the survey. The prevalence of MDR TB was 6.19% among all TB patients. It was 2.84% among newly diagnosed, and previously treated it was 11.60. Among the MDR TB patients, additional resistance to quinolone was 21.82%. This is a case for concern. We can say this is because of the abuse of fluoroquinolones as an antibiotic without proper indication or without going for sensitivity test upfront, which has resulted in developing resistance, and we are losing one important anti-TB drug which can be used in the management of drug-resistant TB. Among the MDR TB patients, additional resistance to injectables is very minimal, 1.3% only. And any first or second line drug resistance among all TB patients is 28%. This is a cause for concern. If you see all the TB cases diagnosed, any drug resistance, it can be to one drug or it can be to more than one drug, that is to the tune of 28%, which means 1/4 of our patients can fail on a particular regimen if you do not suspect drug resistance and put an appropriate treatment for them. So it is essential for us to rule out possibility of drug resistance at the beginning of the treatment itself, rather than waiting for the patient to fail and then direct the drug resistance. Any INH resistance is 11.06 and 25.09. 11.06 is among the newly diagnosed cases. 25.09 is among the previously treated TB patients. This is also a cause for concern. So these things need to be addressed before we give our prescription for any patients who is diagnosed with either a DSTB or DRTB. And any pyrazinamide resistance is 6.9% among the new and 8.77 among the previously diagnosed or treated patients. So MDR TB rates at the national level are still within the range of previous state level surveys conducted in India. However, more than a quarter of TB patients in India have resistance to one or other anti-TB drugs. Fluoroquinolone resistance among MDR TB patients is high to the tune of 28% and is similar to resistance rate reported by the NTEP. The survey results clearly indicate that drug resistance is present in all settings, and the wide range of resistant patterns from any INH resistance to XDR TB needs to be addressed with the strengthening of drug resistance surveillance, universal DST, and appropriate DST guided treatment. These are the figures which we were discussing till now. If you diagnose 100 TB patients, out of that, 77 may be susceptible to all the TB drugs, whereas 22.54% can be having resistance to one or more drugs. Among them, 2.84 may be having MDR TB among the newly diagnosed cases. At the same time, in the previously treated, it can be 11.62. Similarly, fluoroquinolone resistance can be present up to the tune of 24.14% in newly diagnosed TB patients, which is a cause for concern when you prescribe drug-resistant TB management. Please make sure that fluoroquinolone is sensitive, provided the drug is going to be in your regimen. So, having understood all this problem from the National Drug Resistance Survey, a national strategic plan was unveiled between 2017 to 25. It has got 4 components which we are aware, that detect, treat, build, as well as prevent. In the detect component, we have to detect the DRTB, drug-resistant TB earlier, with active case finding, by scaling up of molecular diagnostics. As far as treatment is concerned, the program has taken up injection-free regimens and scaling up of newer drugs or regimens for the treatment of drug-resistant TB. As far as building the infrastructure, there is information, education, communication to make the awareness among the medical fraternity about the possibility of drug resistance, as well as multi-sectoral collaboration to diagnose drug-resistant TB among our newly diagnosed as well as previously treated patients. In the prevent component, contact tracing and TB preventive therapy is offered both for DSTB contacts as well as drug-resistant TB contacts. This is a slide which gives us a clue about the universal drug susceptibility testing which is being practiced in the National TB Elimination Program. In any patient who is diagnosed with microbiologically confirmed tuberculosis, whether it is pulmonary or extrapulmonary, please evaluate them with the upfront nucleic acid amplification test. It can be gene expert or it can be TrueNAT. Find out whether rifampicin is sensitive or resistant. If the rifampicin is sensitive, please do first line LPA to make sure that INH also works, because the level of INH resistance among our patients, either in the newly diagnosed or treated, is very high. So we have to make sure that the INH is also sensitive. So in DSTB, sensitivity to rifampicin and INH should be made sure before starting our treatment. Suppose INH resistance is picked up, then the patient will be going for a INH mono or poly regimen, which we will be discussing subsequently. Suppose if the patient has rifampicin resistance, we have to do both first line as well as second line LPA to make sure whether INH is sensitive for that particular patient. And among the second line, whether the patient is sensitive to quinolones, most importantly, and injectables as a reserve drug. Based on this, we'll be devising an appropriate regimen. This universal DST should be done within 14 days of your primary diagnosis of a microbiologically confirmed TB. That is a program yardstick. The DRTB diagnostic algorithm goes like this. Any patient, a presumptive TB or any diagnosed TB patient, should undergo a upfront molecular diagnostic tool. It can be a CBNAT or it can be a TrueNAT. As I told you earlier, we'll be picking up rifampicin resistance or rifampicin sensitivity pattern. Based on that, we'll be scaling up with first line and second line LPA to find out whether the patient has got H mono or poly resistance, whether the patient has got rifampicin resistance, or whether the patient has got pre-XDR or XDR resistance if they have resistance to quinolones, as well as any one of the group A drugs like bedaquiline or linezolid. So this slide once again describes the same pattern which we suppose if the patient is rifampicin sensitive, what we should do. As I discussed earlier, it should be first line LPA to make sure INH also works before you prescribe a DSTP regimen. How these new drugs act, few slides for the benefit of our postgraduates. Delamanid and the pretomanid act on multiple targets. They inhibit the cell wall synthesis and cell respiration. Whereas clofazimine is a repurposed drug, it can target the outer membrane and possibly bacterial respiratory chain and ion transporters, killing the Mycobacterium tuberculosis. As far as linezolid is concerned, it is also a repurposed drug. It inhibits the protein synthesis. Bedaquiline, as we all know, inhibits the ATP synthesis. So this is the most important DRTB drug to be introduced in the recent past. Para-aminosalicylic acid is considered as one of the reserve drugs. It has got multiple probable targets, which inhibits the folate synthesis, inhibits the DNA synthesis, and inhibits cell wall synthesis. Bedaquiline targets mycobacterial ATP synthase and thereby the energy metabolism of the bacteria. It has limited early bactericidal activity on its own, and the effect can only be seen after 1 week of treatment. The loading dose is 400 mg once daily for 2 weeks. The maintenance dose is 200 mg thrice weekly up to 6 months. Plasma protein binding is 99.9%. It has got long half-life up to 5 months. The main side effect is QT prolongation because of the exposure to M2 metabolite. Hepatotoxicity is also to be considered. Cross-resistance with the clofazimine has to be considered. Very rarely, bedaquiline can be associated with incidence of hemoptysis. Delamanid is known to inhibit mycolic acid synthesis and cellular respiration. The inhibitory effect probably involves the release of reactive radicals such as nitric oxide, which are crucial in the mammalian defense mechanism against mycobacterial infections. It inhibits replicating and dormant bacilli both extracellularly and intracellularly. Common side effects are QT prolongation, electrolyte imbalance, and hepatotoxicity. The dose is 100 mg twice daily. The one advantage with the delamanid is it can act upon both replicating as well as dormant bacilli. So there is one school of thought that we should use delamanid for the preventive treatment as well. Pretomanid is the newest drug which is incorporated in the BPOL regimen. It is a nitro-dihydroimidazole derivative which inhibits mycolic acid synthesis. It is administered orally as a tablet once daily 200 mg with food. Most common adverse effects are gastrointestinal symptoms and vomiting. Transaminase increase hepatotoxicity and headache are not dose-related ADAs. Pretomanid has been incorporated into the BPOL regimen and it was recommended in 2022 itself by the WHO as a shorter oral DRTB regimen. The program has evaluated recently and it is going to be introduced across the country as standard of care for the DRTB patients. Linezolid belongs to the oxazolidinone group, which inhibits the protein synthesis by decreasing messenger RNA translation. It showed anti-TB activity against both replicating and non-replicating bacilli. Dose of 600 mg per day can be reduced to 300 mg per day after culture conversion if ADR happens. The binding of linezolid to human mitochondria can cause myelosuppression, which is one of the most important side effects, peripheral and optic neuropathy, and hyperlactemia. So with this in mind, we have to keep a watch on the hemoglobin levels for the patient. And if the patient happens to be a diabetic, please have a pre-treatment evaluation of the fundus and have a careful watch on the optic nerve toxicity so that these patients should not land up with severe ADR. Clofazimine inhibits mycobacterial respiration via the intracellular redox cyclic as well as membrane disruption. It generates reactive oxygen species, inhibits the mycobacterial phospholipase A2, and mycobacterial potassium transport inhibition as well as efflux pump inhibition. One of the most important drugs repurposed for the management of drug-resistant TB, the most important side effect is darkening of the skin and the cross resistance to bedaquiline. Doses 100 mg once daily. QT prolongation can also happen when simultaneously administered along with drugs like bedaquiline and delamine. These are the several dosages which is given for these drugs for the various weight bands 16 to 29 kg, 30 to 45 kg, 46 to 70, and more than 70 kgs. So with these drugs, the program has taken up 3 regimens for the management of drug-resistant TB. One is H-mono or poly drug-resistant TB managed regimen, which is given for patients who are diagnosed with INH resistance. 6 to 9 months of treatment with levofloxacin, rifampicin, ethambutol, pyrazinamide. All the drugs are administered on daily basis without intensive phase, continuation phase. All the 4 drugs will go. So minimum duration is 6 months. If needed, it can be extended up to 9 months. If the patient is having a rifampicin resistance, the patient can have a shorter oral regimen, which includes bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose INH, and ethionamide, all administered for a period of 4 to 6 months. At the end of 4 months, if they have conversion, it will be switched over to continuation phase of 5 months. If the conversion is delayed, the IP will be extended by 2 more months, so it will become a 6 months intensive phase followed by 5 months continuation phase. In the continuation phase, the patient will be receiving levofloxacin, clofazimine, pyrazinamide, and ethambutol. The recent recommendation of the WHO is whenever you are going to use ethambutol and pyrazinamide in any drug-resistant TB management, in the baseline, you should have a liquid culture DST to check whether ethambutol and pyrazinamide works for them. That has to be asserted at the baseline and it has to be monitored during the course of treatment. Otherwise, there may be a failure because of undetected resistance to ethambutol and pyrazinamide. If the patient is not fit for shorter oral regimen, there are certain specific criteria, I think, which is available in the Central TB Division website. The patient can be put on longer all-oral MDR-TB regimen, which has levofloxacin, bedaquiline for 6 months, linezolid, clofazimine, and cycloserine. Here, the linezolid dose can be tapered to 300 mg per day once the culture conversion happens or if there is any possibility of a ADR for the patient. Regarding the BPOL regimen, a treatment regimen lasting 6 to 9 months composed of bedaquiline, pretomanid, and linezolid may be used under operational research conditions in MDR-TB patients with TB that is resistant to fluoroquinolones who have either no previous exposure to bedaquiline and linezolid or have been exposed not more than 2 weeks. This is a new recommendation for a defined patient group. It is to be used under operational research conditions and thus does not apply to the routine programmatic use. This statement is valid till recently. Now the program has evaluated already the BPOL regimen. BPOL M is the most successful one, provided the patient is sensitive to quinolones. If the patient is not sensitive to quinolone, the resistance is present, pattern is present, they'll be offered only BPOL. Peripheral neuropathy to the tune of 81% and myelosuppression to the tune of 48% because of the presence of linezolid. We have to keep in mind and follow these patients for possible ADRs and then do the corrective measures. This is the diagnostic algorithm for the preventive treatment for drug. My God, thank you for the opportunity. The fact to me, that possibilities of drug all the cases that we have to keep in mind. Possibility of drug resistance is much more among patients who had previous treatment of tuberculosis. We have to use universal drug resistance testing, which is noted by our national TB program to pick up drug resistance apart in all patient diagnosed within 14 days of diagnosis. Employ WHO adopt TTD approved DRTB regimen for the management of drug-resistant TB. With the newer shorter DRTB regimen, the success rate calculation has 70 to 90%. All this insist on a baseline liquid culture DST for types of drug resistance to companion drugs like ethanol, careful monitoring is required as follow to identify possible areas along the way to our DRTB management. Let us all unite together the unconnected DSTB in our population and make that NTB program a great success. Thank you.
See the what's the difference in flow rate between BPAL and BPAL temperature?
BPAL electricity provide phenol sensitive.
How much is the difference in flow rate? Any idea?
More than 10%.
More than 10%.
Sir, just a small word, expert MDR investigation, because in within 90 minutes, it's going to identify both high-NH, neuropilone, rifampicin, and ethanol. So how it's going to further incorporate in the system
program has already a shop doing the expert MDR.
Okay, and what about the WGS?
WGS for the time being, it is considered only as a research tool. Because if you do WGS, it can become various drug resistance. To have regimens for that, we should have a tailored regimen for each patient, which is very difficult for a national program. See, already they have simplified with only 3 regimens for drug resistance. Now, even that is going to be simplified with the introduction of PINPAL or VPAL, where the case is going to be. If the cure rate as claimed in the trials is going to be 2, we will be eliminating drug resistant TB in a faster way if we are going to use VPAL or VPAL for all TB resistant patients. So these tools will be used shortly and already the program is evaluated. So WGS should be kept only for the purpose of surveillance as difficult to treat cases. So that will be only offered as a tailored regimen. It won't be implemented programmatically.
Thank you, sir. Thank you.
Sir, what is the and the emergency diagnostic? Now they are targeted mixed generation sequencing.
So what about nucleic acid amplification test to diagnose MDR-TB?
Gene expert and other these are the two tests which is being used in the program. For the gene expert also has staff. And as Madam said, there's a separate XDR gene expert is also available. So with this we can make a faster diagnosis. But this is for upfront ruling out drug resistance. Then a basic liquid culture sensitivity always is recommended before you start any patient of drug resistant TB management. Find out resistance to companion drugs and confirm the resistance that has been picked up early. Liquid culture DST is the gold standard. This is for hospital.
What about this?
Drug resistance survey mentioned only about INS and pyrizinamide. What was the drug resistance pattern for rifampicin and ethametol?
It's already it is less than 3.
No, it is already it's only 15 16 survey, but
2014 survey in the there. So that is so they did not 3% among the GD diet, but 9% among.
So do they
very well about the drug resistant approach, sir. Kindly enlighten the ongoing program, 90-day program, the multi-drug regimens, which they are following here. There's 3 regimens, yeah.
I start with the before or before that, which is going to be a 6 months.
Can I understand like that? If INX resistance is almost 11% and rifampicin is around 11%. Yeah.
17% amount is I.
So whenever is around 24%. It's not going. Whenever is more worrying than INX and rifampicin.
That's why we start any patient. The second and next patient we available for DRT.
All variants we excluded for
so do they employ genetic sequencing?
Original sequencing is only for research purposes, not for main patient maintenance.
Thank you. We had a discussion on tuberculosis, mainly that is tuberculosis. So thank you. So, next, I will give the motto to our chair as well as the chairpersons. Yeah. Okay, go. Ma'am. Sir, sir, and another ma'am. You know, for the peace and the right turn.
Let's comment on which question.
Thank you.
Selective antifibrotic agent currently under investigation in the treatment of progressive fibrosis ILDs, targeting specific pathways involved in fibrosis. Which is your answer?
We can't see.
Yeah. Which of the following drugs is a selective antifibrotic agent currently under investigation for the treatment of PFLP, targeting specific pathways involved in fibrosis? Please raise your hand.
D.
Sorry, ma'am. Sorry.
D.
Sir?
D.
D. No, I'm sorry, sir. Ma'am already answered D. No, one more chance. Please raise your hand. Yes, ma'am. C. Right. Good job. All right, fine. It was a guess. Yeah, it was a guess. Good. These kind of the price to have. And if you're able to tell me which trial is currently under, it's called the phase trial, which is going. All right. So going on to the next question. Which specific genetic alteration is associated with resistance to both EGFR type kinase inhibitors and therapy in non-small cell lung cancer?
Which one? Yeah, really make it. How does that stay?
Sorry.
790 C. C.
Is your hand row on
C.
No, sir. Sorry, I don't think I'll be able to give anyone this question. Next question. Next question. What's the accuracy? 790 mutations. Okay. Yes, there was someone who answered it, but of course, answers were without. Yes.
All right. Sorry. Yeah, in patients with COPD, which of the following mutations has been associated with an increased risk of early onset COPD and is related to abnormal lung development and inflammation? We have many people who are raising their hands. Please by 8 seconds. That they're raising hand person. Yes. Sorry, no. Not much. Take it off. Now, yes, yes, you're see. All right, yeah, you got it.
Lakshman. Not still.
C. Yes, ma'am. See, don't come all right, my business group, so rule and your part. The answer is science we are someone actually speak for the answer. Yeah. All right, fine. This session halts for now. Have a small lucky draw. All right, for all our guests. The names have been enrolled by the Pharma people into the pot. We request Shivani ma'am to tell the lucky draw winners.
So next our branch. So congratulations. Just make sure. Please. Yeah. Next one. So, we know it. Okay, now we go on to the next important session on sleep session. May I request chairpersons, Dr. Manimaran, Senior Consultant, Director of Respiratory Medicine, International Pulmonology from MAOT Hospital. Welcome, Manimaran. Dr. Sanmugapriya, Assistant Professor, Lalitambika Medical College. Welcome, ma'am. Dr. K. Sridevi, Senior Consultant Pulmonologist from JDK Hospitals. Please take over and start the session.
Good day, everyone. I think today's speaker, the keynote speaker, needs no introduction. Definitely, Dr. Shivani Swami, who has come all the way. She's done a lot of work in sleep medicine. She is currently consultant pulmonologist, director, Narayana Multi-Speciality Hospital, Jaipur, and she is doing a lot of work with regard to sleep. She is secretary Southeast Asian Academy of Sleep Medicine, and shortly the conference is also being organized next month at Indore. And she has also been elected as a governing body member in Indian Chess Society recently. Congratulations on that, ma'am. And she is also a member in CCI, American College of Chest Physician, member in ERS and the United Academy of Pulmonary Medicine. So over to you, Dr. Shivani.
Thank you, ma'am, for the kind introduction. And thank you again to take. Very well. I really look forward to the interesting academic interactions that can happen only in the South, which I think the scientific flavor of the South is something which we are still not completely able to adapt in the North. So I am talking about obstructive sleep apnea clinical challenges, when and how to intervene with case examples. I am going to keep, I have kept my talk really simple. I am talking about only the cases that we probably see all of us in our day-to-day practice. And especially for the PGs, I'm going to go slow because I'm going to introduce a few new terms about the settings, which you would probably find very helpful in your future practice. So the cases that I am discussing, first is on patient on auto CPAP experiencing full dryness, patient on auto CPAP unable to tolerate the device, treatment emergent central sleep apnea after being put on auto CPAP, patient on CPAP unable to fall asleep due to the high pressure, patient on auto CPAP experiencing suffocation like sensation after falling asleep, and patient on auto CPAP for 9 months starting to feel that the device may not be working like it used to. So these are the 6 cases that we are going to discuss, starting with case 1. So this is a patient who is a shopkeeper and complains of excessive daytime sleepiness. He's 55 years of age. His BMI is 28. He occasionally consumes alcohol. The diagnosis that was given to him was obstructive sleep apnea with an AHI of 34, which makes him a case of severe obstructive sleep apnea. He has no other sleep disorder, no other comorbidity, and a titration study which that suggested a pressure between 8 to 14 centimeters, the 95th percentile of pressure being 14 centimeters of water. He was then prescribed auto CPAP and he started using it again. But then he came back complaining of excessive dryness. So we talk about humidification, and we all know as respiratory conditions that there is some natural humidification which happens in the air that we breathe, which is the primary function, the nose. So when we breathe naturally, our nose will act as humidifier, warming up the air to our body's temperature. But when you are breathing through a CPAP or any PAP device, of course, it's giving you pressurized air, which is extremely dry, and it further dries the nose and throat. So what does the humidifier do? Actually just add a little bit of humidification. And when did we start talking about it? We started talking about it in late 80s. However, in 2001 was the first paper that was published in the chest which said that humidification is something which can be a game changer, at least in terms of compliance when the patient is using PAP therapy. Because we all know that non-compliance is actually the major issue which we all face when we are prescribing PAP therapy to these patients. That 6 months, 1 year compliance is really, really poor. So humidifier is more little change actually improve that compliance major. So but then do you think that attachment humidifier is all that we do? No. It also has its problems. The patient may actually come back to you that either the humidification is prescribed till experiencing dryness, or it can actually come to you and say that there is something that there is a lot of moisture and he can actually feel the water droplets on his mouth in the bath, and which this phenomenon is called the rain out. What do we do for these? So for the first problem, you can actually just manually adjust the level of humidity. Just maybe increase the level, and that's also fine. And for the second problem, you basically have to maybe switch to another device. But of course, in India, the major challenge may evolve. So for my patients, I actually always tell them that if there is a rain out happening, the first step that you do is maybe try and keep your machine at a slightly lower level than your bed. And that usually also solves out the rain pressure. However, if it does not happen, there are these heated climate control tubings that are also available, which can be added. What it does is, it obviously adds humidity, controls the temperature to around 27 degrees Celsius, and hence prevents the rain out. There are various modes now in the newer equipment. Of course, there is manual humidification. There are also equipment which provide auto humidification and rain out protection. You can use either, and of course adjust the humidity level and the climate control accordingly. Coming to the second case, this is a patient, Mr. Prakash, a businessman by occupation, complains of tiredness, morning headaches, and daytime sleepiness. 65 years of age with a BMI of 33. He drinks socially, is diabetic, but is not hypertensive, and no other comorbidities. He was diagnosed with obstructive sleep apnea with an AHI of 54. He has no other sleep disorder. A titration study suggested a pressure of 17 centimeters of water, and the patient did try to take an auto CPAP for trial, but however, he was unable to sleep with it for over 2 hours. He felt that the pressure was too high. All the comfort features were added, and the patient still felt uncomfortable while using the device. So I'd like to ask the PGs if they're awake and listening, what do you do with this patient? The PGs, anybody? Like to say that sleep apnea is something which is extremely tailor-made therapy. There is no one size fits all. You cannot just prescribe an auto CPAP for everybody and forget about it. It needs really focus on the patient's needs, requirements, and a lot of things needs to be taken into consideration. There is no right therapy for every single patient. Every patient is different. So of course, when we've done the sleep study diagnosed the patient who has sleep apnea, we either give them an auto CPAP or a CPAP. But is that enough? When the requirement of the pressure is as high as 17, anything over 16 is something that the patient is going to find extremely hard to exhale against. So it's extremely difficult for a patient to exhale comfortably against such high pressure. And that is why the equipment actually gets really uncomfortable. And that is when you really consider switching to an auto bi-level device or a bi-level device. An auto bi-level device would have 3 modes. You can obviously choose the mode depending on the patient's requirement. There is a CPAP mode, a spontaneous mode, and a big auto mode. What a auto bypass does is you basically set these 3 settings, which is the maximum IPAP, the minimum EPAP, and a fixed pressure support, which will be delivered. So depending on the patient's requirement, it would deliver a different amount of pressure, but the pressure support at any given time remains the same. The equipment actually picks up how much pressure to deliver depending upon the response to airflow limitation, the snoring episode, and apnea that the patient is having. Of course, there is clinical evidence, enough evidence to suggest that it improves compliance in patients who have very high pressure requirements. In fact, if you see and look at this study that was done, and you see that the patient's compliance at 3 months and at 1 year was much better compared to CPAP or an auto CPAP, and they had lesser side effects like nasal stuffiness, eye irritation, mouth dryness, choking sensation, and aerophilia. So it definitely also improved the quality of life in these patients, and the acceptance and compliance was much, much better. So we auto mode may be a good option for patients experiencing pressure-related side effects. So if the pressure requirement is extremely high, this might be a mode that you might want to switch to. Now coming to treatment emergent central sleep apnea, then I want the residents to please stay awake, even though this is a sleep lecture, please. Patient Mr. Ramesh, retired government officer, resident of Himachal Pradesh. He was aged 68 years, the BMI of 36, and complains of early morning headache, non-diabetic, non-hypertensive, but the known case of congestive heart failure with left ventricular ejection fraction of 30%. He was diagnosed in a sleep study who had obstructive sleep apnea with an AHI of 50. He had no other sleep disorder. A titration study suggested a pressure of 13 centimeters of water. The patient took an auto CPAP device on regular, had been on follow-up, but was found to have central sleep apnea with a central sleep apnea index of 17. Of course, the patient continues to have the same symptoms, and he says, I still do not wake up well. So what is the use of using this machine? And now I find that we are central apnea. So what do you do? Of course, we all know that breathing is regulated by chemoreceptors and of course also the respiratory control center in the brain. The normal breathing pattern depends on age, body composition, level of consciousness, environmental conditions, etc. And it is also impacted by sleep. We do know that there are physiological changes that occur even in respiration while we are sleeping, which includes the decreased minute ventilation, the increased PaCO2, the decreased ventilatory response, and of course, the breathing becomes more shallow and the rate is also slightly reduced as compared to our awake state. But what happens in OSA patients? The airway is obstructed, the level of CO2 rises further, oxygen levels fall, which is basically the rise of the patient breathing. But then we also are aware of this concept, which is called the apnea threshold, which is when a patient's carbon dioxide level falls below the normal range and enters the apneic threshold, that is when a central apnea occurs, that is the dry breathing is affected. So this is what is happening in a central sleep apnea patient, that even though the airway is open, but because of the low level of carbon dioxide, the patient, the brain is not actually signaling the patient to breathe, and hence the airflow is also compromised. We are aware of what the obstruction sleep apnea is, just so what the central sleep apnea is. But there is also another term which is called the complex sleep apnea, which is central sleep apneas which persist or emerge only during treatment of current sleep obstructive sleep apnea or using a CPAP or a PAP device. So how do we treat this patient who basically has a complex sleep apnea? We do know that central sleep apnea is usually seen in patients of congestive heart failure, patients of stroke, brainstem injury, patients who be using opioids, or of course complex sleep apnea that our patient just seems to have. This is how I work of central sleep apnea looks. So if you see this, there is actually no airflow and no respiratory effort. So this is how exactly a central sleep apnea would look on the polysomnography. The treatment options that have been discussed in literature so far are oxygen, addition of dead space or rebreathing of carbon dioxide, various respiratory stimulants, diamonds, and sleep repositioning, however, which is not really a very practical approach. So, is there anything that we can do for these patients? We diagnose them. We diagnose them to have either a complex sleep apnea or central sleep apnea, or maybe a change of respiration. So, what do? We evaluate it for hyperventilation and then consider maybe adding an advanced mode like a ST BiPAP or a IVAS. However, if they have complex sleep apnea or they have treatment emergent sleep apnea, you may actually consider adaptive servo ventilation in the auto mode or the manual. What exactly is the adaptive servo ventilation? And who are these patients who may actually be benefited by it? These are these patients of treatment emergent central sleep apnea, patients who be using opioids, the chain strokes, respiration or central sleep apnea cohort, and of course, it is absolutely contraindicated patients who have advanced COPD, who have hyperventilation because of anything or who are restrictive or neuromuscular diseases. So those are not the patients to be treated with adaptive servo ventilation. But what does the adaptive servo ventilation do? It is basically designed to stabilize the patient's minute ventilation by automatically making pressure support and providing automatic dynamic respiratory rate where needed. The basic indication being that the patient has to be weighing over 30 kgs and should have maybe a treatment emergency vaccine or other indications that we have just discussed. However, there were multiple studies which said that these are the adaptive servo ventilation can actually lead to increased mortality in patients of heart failure. But then there was this very recent paper which came out in 2024 in the Lancet, which said that the adaptive servo ventilation actually has no effect on the mortality. This was a study done on over 1100 patients, it had to be prematurely stopped because the equipment that they were using started ranging free for some other concern. However, the study concluded that there was no effect on mortality, and in fact, if you look at the final range, that when the patients were had the mortality was actually higher in the group that was not receiving ASV. So basically, they concluded that there was no effect of adaptive ventilation on mortality compared to what was believed or revealed. So patients with central sleep apnea, when they are not adequate intervention CPAP or bilevel, then they would actually switch to the advanced modes because their quality of life, their compliance, the conventional modes is actually going to be extremely poor and they may always be symptomatic, even though the therapy you are delivering is probably okay, but their apnea index remains high. So for these patients, because bilevel is ineffective for various reasons, the adaptive servo ventilation would monitor average minute ventilation. It would leave the airflow in these patients and then deliver pressure accordingly. And if there is an apnea, also deliver a back rate if needed. That's how it works. Of course, there is a new mode. There is also the auto mode, which has just been introduced into it. And it is actually a combination of adaptive circular ventilation with an auto set mode, wherein it just plays around with the different pressures that the patient needs, and everything is taken care of. The basic algorithm being the same, that it responds to flow limitations, tone, and obstruction on the next breath and proportion to events subsequently. How do we titrate this equipment? Now, this is extremely important for the PTs. So, what the machine does basically is reading the apneas or the hypoapnea or the snoring events that are actually happening while the patient is sleeping. But how do you adjust the setting? The default settings that this equipment comes with is a EPAC of 5, a minimum pressure support of 3, a maximum pressure support of 15, and a ramp which is switched off. What a ramp is, I'm going to discuss subsequently. However, there are these three parameters that you can still play around with, which is the EPAC, the minimum pressure support, and the maximum pressure support, which you can adjust on the adaptive servo ventilation depending on the patient requirement. Of course, this is only the limits that you are setting. The machine will itself read the algorithm and adjust the pressures accordingly. However, in a auto mode, you can also adjust the minimum EPAC and the maximum EPAC, and not just the EPAC, and then the minimum pressure support, maximum pressure support. So it is just an added couple feature. Coming to the case 4, a patient who is unable to fall asleep. This is a taxi driver Rajesh, 68 years old, complains of early morning headaches, non-refreshing sleep, non-diabetic, non-hypertensive, obstructive sleep apnea with a HI of 53. He has titration study suggested a pressure of 11 centimeters of water, and at that time he had water, sleep disorder, sleep complaints. The patient is CPAP device but has been facing difficulty falling asleep and complains of high pressure. So high pressure experience initially, what was that? Yeah, the RAP and 0 to 45 device. Now what the RAP actually does is gradually increases the pressure right from the time that the patient sleeps to the healthy pressures within that time that is set. So the pressure that the patient faces is actually not going to be extreme the moment that he puts it on. However, there is also an auto ramp feature which I am going to talk about. The patient you also have to consider may have other sleep disorders like a concomitant insomnia along with sleep apnea, and in this case, might actually want to repeat the PLG and see if he does actually have insomnia and then treat that. So talking about the RAM feature that I was talking about, it can be set manually between 0 to 45 minutes. It would increase the pressure gradually every 5 minutes, and it is just actually a comfort feature. It gradually builds up healthy pressure, and hence the patient may actually not feel extreme pressure right at the moment that it's sleep because it doesn't feel the pressure when it has is away. And even when he falls asleep, the initial pressure requirement may actually be not very clear. So till that the runtime is over, the device won't react any event. So when we put it up manual time, if the patient falls asleep early and there are events, the only drawback is that the machine is not going to react was apneas and non-breathing decompression until the ramp time is over. And this was eliminated by the addition of autorack, wherein the machine actually can read whether the patient has fallen asleep depending on the algorithm, and it keeps increasing the pressure. So it is able to detect whether the patient has slept based on the airflow and the breathing, if there are any obstructive apneas or hypoapnea, any storage, or if there is a consistent metronomic breathing that is indicative of sleep. So the machine have actually become extremely smart and the all comfort features which are extremely helpful in adding on to the patient's comfort and improving compliance. However, there is also a autorack cleansing. So if the sleep onset has not been inferred within the first 30 minutes, the pressure will rise no matter what to achieve therapy pressure or minimum pressure in the set within the 30-minute range. So if you want to gradually start increasing pressure, if for any reason if you feel that the patient has not slept. Coming to the phase 5, a patient on auto CPAP with disturbed sleep. Patient Suresh is a small business owner, age 48 years, BMI of 29, stage of daytime sleepiness, pre-diabetic, non-hypertensive, diagnosed to have obstructive sleep apnea, HI of 43, no other sleep disorder, a titration study suggested a pressure of 14. Patient took the device but complained of high pressure, which disturbs the sleep in the middle of the night. Of course, this is where it's probably called a particularly difficult to exhale against high pressure and may complaints of disturbed sleep. So what do you do here? Maybe just add a EPR. EPR is an expiratory pressure relief feature wherein you can allow the machine to drop the pressure by 1 or 3 centimeters of water when you breathe, then the patient is expired. So during inspiration, there is a higher pressure. During expiration, there is a lower pressure by up to 3 centimeters of water, and that is a comfort feature which is added to make it more comfortable for the patient. However, if the patient does not respond to that condition of PR, consider into with the manual retitration, and if the pressure requirement is very high, then we switch to a more advanced device. The EPR we discussed that increase the pressure between 1 to 3, reduce the pressure between 1 to 3, and is a comfort feature, is persistently delivers the pressure, and there are 3 levels that are available. However, auto-set soft, there is also this feature of auto-set soft response. This is another new equipment there. People do not have severe sleep apnea, but have a lot of air limitation, wherein you want gradually and softly increase pressure, not radically increase the pressure. There is a auto-set soft response, which increases the pressure but very softly. So rather than increasing 1 centimeter or 2 centimeter, it is some around 0.5 centimeter. That is how rapidly increases the pressures for these patients to become more compliant with therapy and not really get them uncomfortable. Now, my last case is existing or CPAP who are having problems. This is a Mr. Rajkumar, the chef with a 5-star hotel, 51 years with a BMI of 30. Had phase 1 for the CPAP the last 6 months and doing very well. He's pre-diabetic, non-hypertensive, using the device, and has been doing for 5.5 hours of an average day for the last 6 months. And he has died. Recently, patients started observing high phase 1 poor HIV and return of the symptoms of monetization and sensitiveness, which have been impacting the daily routine and work production. So, what are the possible reasons? In 6 months, there has been being finished, and now suddenly we have the reaverted process. So, maybe it is not really one up. Maybe the patient is not sharing the transparency. May not be, mask may not be able to create information. The device is not being for the time, and the device or maybe that survey. These are things that we think of, and also important at this point, ask the patient to come back and there's a lot of difference sometimes. See whether this mask which is the problem or whether machine is not working effectively, then what is gauge has been, why they are being. So a detailed compliance report may actually give you here. However, it's extremely important that get good compliance, then the mark which is extremely important, and you have spent a lot of time in explaining them how the mask has been dealt with the marketing, that's the vibration, the body language is like that. When sometimes the patient make sure that the marketing is done right, is done, and not in the time. There are various types and types of available, which obviously depends on the patient's needs and also the patient's comfort. So there is the full face mask, there is the visible mask, there is the basic mask, the basic bill, and now there is the visible mask which actually doesn't cover from the reduction but set to at the long-term and the rest is the mouth and it was these are only sources. There are various masks that are available. It is extremely important, and we have to make sure that you see the type of when they're trying to get the vehicle actually has get then they can pass this movie the in between the vehicle and the page to make sure that it's not tight and the sizing of course actually done properly and there are class with everyone. Make sure the size from the bigger. What's the part it has to be like you know the one level of what it look like has to come down. And if you are using one nasal mask, there is a different card available to see if the size is right. Then there is different cards for the nasal available. So right before you put on a mask to somebody, make sure you use this card. Make sure that the size is appropriate for this particular patient. However, if the patient has any nasal obstruction or DNS or polyps or anything, you cannot give this patient a nasal mask even if they are comfortable with one. If they are mouth breathers, then again they have to switch to a mono-nasal mask, and that is what's important. But then there are some patients who have claustrophobia, cannot already follow the nasal mask, then just give them a chin strap with a nasal mask that their mouth remains shut while they are sleeping. Of course, some people may need a lot of counseling time that you need to devote, make them comfortable, understand the physiology of the disease for them to be able to use the mask. Also spend some time with the patient trying to tell them once they start using it, how to clean it. They have to clean it with a mild detergent and water at least once a week and then dry it out again. Replacing the various parts of the equipment as is recommended, like the pillows, the tubing, the velcro, which we can get, or even the printers, which would need regular change. Servicing the equipment at least once in 6 months, and then, of course, maintenance of all of this equipment is extremely important. And in a lot of countries, even if you're not maintaining your equipment or not using your equipment, insurance actually doesn't cover the morbid illness that you should get. Unfortunately, in our country, insurance still does not recognize sleep or the disorders as one of the major entities and does not cover it. But in a lot of other countries in the Western world, that is how it works. So with that, I'd like to conclude. And thanks very much for your time and patience.
So, Dr. Shwani, I see small issues definitely bigger legal complaints. Small few questions. How long we need to use sleeper? Minimum hours there. Question number two, those doing night shifts, the daytime, how practically they get in the daytime.
Very good question. So first question that how many hours we need to use this? So American Academy of State Medicine recommends we need 6 hours every night for at least 4 to 5 times in a week. However, I am of a different opinion. I tell my patients that they need daily. Because if you tell them 6 hours, what happens is that you probably put it on at 11 and they will want to reach it by and then go back to sleep. And when they go back to sleep, that is actually the time that they would have more numbers of apneas and sometimes even good numbers of people they're getting more than 3 So I don't really like them keeping it off. And I usually recommend that use it for alcohol sleep and for as many nights as possible, preferably every night. And sorry, coming to the second part, because the shift work disorders. So if they're working in the night, then of course they're sleeping during the day. Studies, various data has shown that the quality of sleep is not going to be the same in the day as the night, and that goes to and leads to an increased incidence of comorbidities in patients or shift work disorders who are working in the day. However, that they do use it whenever the day. However, quality of compromise. Also, I think the impact timeline is being prohibit people from working in a specific shift for a longer duration.
Yeah, that was really wonderful presentation, Dr. Shivani, with so many, different case scenarios. So on this, we are receiving so many patients, the patients themselves are subjecting, for a sleep study by themselves and coming to us with a report, and we are getting a lot of reference. And also, I think, the counseling has to be done to the patient's the partner as well, I feel. Because most of the time they are at the receiving end. So before the therapy, because of the snoring, they have sleep disturbances, insomnia, and even after the therapy, they do complain because of the loud noise from the machine, they are not able to sleep. So how do we address this issue? Because
So definitely, and I think feels like the most times people also complain because they've been dragged by the partner that the chicken is not interesting because of their story. Definitely that remains a major issue. And you need to counsel them about the entire theology of the disease so that they are aware of the harmful effects may have on their health and are complying to using it. But definitely a sound noise equipment is something that is a very common concern for the partners as well as correcting pointed out. So most times the heart is alright. That the rushing sound is actually eliminated. However, little sound of the machine does fit. I think with time and with more technology coming, we should have more. We've come along. We should have more advanced in which we minimize the sound pollution. And most definitely, I think there are drugs on the market for reducing the severity of sleep apnea. I have personally not used it yet, but it has recently been approved by UNICEF. And it is said to not just reduce weight, but also reduce the incidence of sleep apnea in these patients. So maybe pharmacological therapy is going to be the way forward. Regarding your case, I think it's central sleep apnea, right? Yes. Okay. So you said ASB deficiency. So how does it differ from IVAX or AVAX? The same set ventilation will be delivered with this machine, and that also delivers the set tidal volume. So how does ASB differ from IVAX? Because ASB is not available in all our machines, but IVAX is available in all our IVAX. Extremely good question, ma'am. So I think the basic difference that what IVAX does is delivers an assured volume irrespective of the dynamics of the airway that the patient has at that point. And is majorly indicated for all cases of hypoventilation for whatever is the cause. So very it can easily be used for our patients respective breathing, but no other thing as well. However, still talking about the air breathing, but I think it is substantially it is not the breathing hyperventilation, but the actually addressing is the careful lifting. What it doesn't deliver a short brain, but placing the pressure just put the airway and the volume is delivered on its way. I think almost a similar function I have also done, right? So in the case where you have a cardiac failure patient of things later, it's better to go with IVAX or go with AS, right? Just keeping the IVAX because there was a contradictory data saying that ASP per increases mortality in congestive heart failure. we have been using IBAS, and this is a very recent paper that I came across. This is actually the only paper, and this study cited that had been appreciated in between was the equipment that they were using was responsible for it. So I'm not really sure. I think we need more data to support that. It's for the research. Then in the next phase mode, that's the new mode you talked about, right? So the comfort during expiration, the pressure drops as the patient is able to breathe. The EPR. Yeah, EPR. So the same functions can be, I mean, in IBAS, you have a trigger and your lifestyle. You can adjust the trigger and the lifestyle to achieve that the pressures to fall during your expiration so that the patient feels better. Yes, and like earlier, that were in like IBAS, which you can expand the data, okay? But now this comfort feature is also coming into CPAP, which is a great addition. Thank you, thank you.
Yes, sir. Dr. Shiva, very respectful for sharing everything and giving your approaches, the identification of the problem and your equipments and methodology all are customized. That is what you are coming to. Your derivation is a customized approach. Yes, right. There's no hard or fast rule of the equipment like that, the duration or methodology.
Yes, I like to tell my patients that every patient fraction is the factor level. It's just extremely data. You have to access the area. Actually, even for sleep therapy, I always like to say that the patient also has to be patient, and then the attendant also has to be because
especially the latter, which is there. Yeah, the triggering factor. Right? Very nice.
So much, ma'am, for those interesting plethora of clinical cases and enlightening us. I would request Chairman sir to come on to the dais to facilitate our speakers and chairpersons. For lunch, I request all the faculty members to assemble on stage for a photo and then followed by with everyone.
Because I was actually how the please to the chair is a friend. Right.
And the proceedings after the lunch will be, we have panel discussions by Dr. Kaushik with our panelists, esteemed panelists, followed by our workstations, which also have quiz rounds and draws. So kindly stay till the end.
I think so. The writing is passing here. Take it total now. Then all the case PGS everybody. First the backend session photo. Then it's all the backend case. So please.
Chat. Remove the chest. The two chest. Stop. So now.
Thanks. It's requires all the questions. All the delegates, when PGs, everybody should come forward and take the group photo. Come on. You know what? I need to go on. Then you don't have one more round of the season members. Season team next time. Request everybody, please come forward for the group photo for all faculties and delegates. This is the second photo session. Third is for the CSM members. CSM. Oh, okay, yeah, that's your
On to this file. Wait. Okay. Thank you. We have conversation on CSM. Some of these Asian academic person. Those who have not joined the CSM, can request you to join the Southeast Asian academic person class right October 5th and 6th. 5th and 6th, we have a international conference on trade disorders. Please.
I'm showing it.
Please join the lunch now. Thank you.
they have to. I request Dr. to chair the session. Dr. Kabali sir, he's a consultant at Prashant Hospital's Velicheri. Sure, and welcoming our next speaker, Dr. Raja sir, Professor Sri Ramchandra Mandri College. So was also my mentor during my postgraduate days. I hand over to you, sir.
So said I thank the organizing team, Professor Jayaraman and his team for inviting me to give this talk on case discussion about EBUS. So I have three cases for the panel. 7-year-old female. She had complaints of cough and scanty nearby expectoration for the last 7 months. She also complains of generalized weakness. She complains of significant weight loss of about 20 kg over 6 months. Past medical history, known case of type 2 diabetes mellitus, partially controlled, and then no other known comorbid. General and systemic examinations were unremarkable. So, and this is the X-ray of this patient. So I would like the audience or panelists to comment on the X-ray. Pages, would you like to comment on the X-ray?
Please come forward and answer the question. Ready diagnosis.
Anything? Pages?
Yeah.
Any comments for the pages? Okay. Panel?
Very electrical question and the problems.
Okay. So we have a right paratracheal widening and also bilateral hilar prominence, and it is also shows a 1, 2, 3 sign. So what we did next was a CT thorax. So following that, we with the okay. So I had a very important, which is accessible in through a EBUS or through a CT guided CT scan guided work. So which modality would you prefer in these cases? We prefer EBUS because it's a central lesion, which is near the area. So yeah, very good. So it's a centrally placed lesion. So we'll be having more yield and more diagnostic material when you're doing a EBUS rather than a CT guided biopsy, and there will be less complications as well. So what are the differentials that would consider in such kind of a picture? We are sarcasm and also doing very less. Okay. So one which is you saw the history of 20 kgs weight loss in this patient. So that fits with anything much more than with- that fits more with which condition you yeah. So yeah. So we had three differential diagnoses. One is as discussed tuberculosis, sarcoidosis, and lymphoma. So we went in and did a EBUS cDNA and so this is station 4R, and so station 4R, ideally you will identify with inferiorly placed superior cava in your EBUS scan. And then this is station 7, your subcarital. And then this patient also had a 11R superior and 11R inferior. And this patient also had a 4L node. And then also had a 10L and 11L node. So almost all lymph stations were lymph node stations were involved. So we did a TBNA with the 11RI. So in our experience, what we have understood is the lowest possible station gives you more yield. For example, if the patient is having 4R, 7, 10, 11, and 11RI. If your 11RI is possible to do a sample, then that gives you much more yield compared to the 7R for your highest station. That's what we have analyzed over a period of time, especially in malignancies. So we generally prefer doing it from the lowermost stations because for us it has given better yields. So and then we did a EBUS TBNA cytology. Anybody wants to take a comment on the cytology? So and then we also did a core biopsy which was sent for HB. So the EBUS cytology was positive for granulomas, which was not caseating, and then predominantly compact granulomas. And the core biopsy we sent for histopathology also showed dense compact granulomas more in favor of a sarcoidosis. So we also did an additional investigations like AFT was negative, gene expert MTV was not detected. The bacterial culture was negative, and we also say CD4, CD8 for most of our patients, which was very much elevated in this patient, more than the cutoff up to 7. So the site 49ers, AC level was also high, somewhere about 87. And then finally, we came to the diagnosis of stage 1 sarcoidosis. So this is the first case which we wanted to highlight the importance of bronchoscopy and EBUS together can actually give you a diagnosis at that spot or on the same day, rather than going ahead with CT guided biopsy for centrally placed tumors. So, going to the second case, a very interesting case. It's a 42-year-old male patient who had complaints of dry cough for 10 months, complaints of right sided chest pain on and off, and again had a complaint of 10 kg weight loss and over 10 months. So the past medical history, not a known case, not a known comorbidity, not to say have not no comorbidities, and general and systemic examination was unremarkable except for a scrotal swelling. This is the X-ray view of this patient. So anybody wants to take a comment on the X-ray, PGs? Second.
floating with high, no high up and also high guard, but is completely obscured. A slight wind end of, right in there from last. So the whole is everything is there.
So what next? What next for this failure? How do you proceed? So we went into the CT. Yeah, CT. Anybody wants to come on the CT? Just confirm the X-ray finding of right hilar mass, and some kind of necrosis is also seen inside. And so we went in and we did a EBUS. This is the right hilar mass. It was close to 3 centimeters. And then what we found was this patient also had multiple other stations in EBUS, but then those were not reported on the CT scan, which was actually written as subcentimetric lymph nodes. But then what we found was it was more than subcentimetric. And then we also had 4L, 7, 4R, multiple other lymph stations involved for this patient. So this is the video. Consistency. Post consistency was little hard for us when we are jabbing. So it was the initial 2 3 passes was a little bit hard. And then so any differentials at this point? What would be the
Sway. So when you see a node, there are certain sonographic features which points us to know whether we are dealing with the benign analysis. And particular specific diseases, we have some pointers. If you get a sarcite, so as per the usual teaching, like we have low range of appearance. You see the sarcite, clinical whatever people appearance. The same way, if a node you catch that whole field in that even small node, you could see that luminate. So here also you see one projection is there and adjoining that one projection is there. And what you are seeing is a lot of linear artifacts are there. You can see that beyond the node, what we are seeing into this feature, you see a lot of linear artifacts is there. What is a well-defined hyper-echoing? That is also there. With all these features and even vascularity, do you have any Doppler?
there was no internal
Nothing. And other things like you can see 2 3 nodes, you can see that conglomeration that is also there. Like the feature of periodontitis is there. Like that will be there in TB. And then sometimes sample also may be there. Like you see that 2 3 nodes will be there. Once you start scanning a node, doing a sampling, you also see a node matches a node which is also like close to the node where you're sampling. That is also there. I think here 2 3 bumps are there.
So any primary involvement of the mass. There was like a real opportunity doing a DBN as a pulmonary animation is I will approach it the same. That is really from and there is no specific.
Only they have a discussion like if a node is there, usually we tend to have a fear to put a needle in the close to the pulmonary. But if there is no chance, There is no other chance to get a say other option to sample the node. There's no you can just go ahead with sampling beyond the pulmonary.
It's like any intramodal bleed, you don't have to be worried. Even if you puncture the pulmonary artery, then large volume will be there. So by just puncture it on the slip side, identify a better side which you avoid the vessels and puncture it. Right? So you won't have any complications.
So most of the things detail also is very 21 and 25 guys putting that into a vessel, the arterial wall with a very thick wall. So I told this to cardiologist actually when we are discussing. They are telling that it's not routine. What you are telling me as if you have done a like heroic job. We are putting little lady in and out the artery, aorta and pulmonary artery. The thing is that the vessel wall is talking. The vessel wall is good. Nothing is going to happen. It's for aneurysm, brain dialysis, or you have a severe PhD. You can do. And once you puncture into the vessel, you have to create a single track. You should not do a split or multiple track and do a seam like appearance. Single track, go there and then take the aspirate and then come out. With the rose, I think it will help.
Only thing is very have to be worried is somebody old age who have high chances of getting an aneurysm and probably getting pulmonary hypertension. Obviously, to take a call, but you have to go ahead and do the procedure. It's going to be very severe. So that part is. So surprisingly, what happened is we had a atypical cell positive for this patient on site once. And then we waited for the final report. The final report was this. Had a CD30 positive and PAX5 positive and suggestive of Hodgkin's syndrome. So,
Yeah, radiologically, I think two things. You have likely the panels also explained the EBUS findings, but radiologically also, I think there's more hinting towards malignancy. Like,
initially, what happened is when we went and we thought it was a hilar mass and we thought it was the malignant. Our clinical diagnosis was very malignancy, you can see here. But we thought it was primarily a hilar mass, but it's almost correct. Then we also had a suspicion of still lymphoma. So, mandate was a lymphoma with CD30 and PAX3 positive. And we underwent chemotherapy, it's perfectly fine. So coming to the final case, it's a very, very interesting case. We recently did this case like 3 weeks back. So 38-year-old male, non-smoker, identified with the lung nodule on a mass culture. He comes to the OP with this picture. There is a right upper lobe nodule. So this was the nodule. Tagesh, can you comment on the nodule? So it's right upper lobe in a chemical segment. Mostly it's a well-defined lesion. I think the size of the bullet is significant, like it's yes, mass kind of thing. Was yes, the intra-nodal necrosis. So what we did was we went and did a PET CT for this patient, and then this was the PET finding. This nodule was almost nodule or mass lesion, just a nodule, nodule. And then it also had a CT bronchus sign positive. And then SUV uptake was close to 9. It was a very hot nodule. And then so what would be a next approach to these kind of scenarios for hemorrhagic actually, sure, yes.
Positive bronchus sign is there. The lesion is well defined. We have to go ahead with image guided sampling. That is usually sonographic guidance. We have EBUS. The question is usual school of thought we go with the ready EBUS because it's very easy. Bronchus sign is positive. That is mentioned. That means that the lesion can be having a circumferential view and the chance of getting positive very high. But what I am seeing is this lesion is very proximal, close to the main bronchus. You can very well get to the linear neighbors under direct guidance. So this is what we are planning to do a study. Even you are those are ready neighbors. Those are linear neighbors. If it is in the proximal bronchus, and through direct image guidance, you can puncture it.
I think sorry for not putting all the images for discussion. I think that may be a bit of bias saying this particular strange now. But then this lesion was actually sitting in the sub-segment of the anterior upper lobe. So the right anterior upper lobe subsegment. So Harish was sitting there. So what we did was going to trade university with so I think most of the centers who are not having a ready label or EBUS as such will go for a CT current biopsy. The whole point why I'm projecting this is how could one small tool in your kitty could actually change the complete pulmonology practice. So we went ahead and did a radial EBUS for this patient, and then so say anterior upper lobe and the subsegment was the lesion. It bleeds on touch. It bled on touch for us. And then we did the radial EBUS imaging for this patient. And Rakesh, I think you would be the better person to comment. I think you are to take the ball on the sonographic view. And you're also trying multiple other segments. So for this patient, we had a sheet left inside, and then we did a this is from so now we could see a well-defined challenge. So this is a concentric image which we have made. And can you please image? So in this image, you can see the center point was center point and the concept correct this concentric pattern. So the heat with the concentric pattern, like Tanya said in the morning, it goes up to 80%. Correct? 80%. So this is your radial groove which you are seeing in the lesion whenever we focus it. So you can see these are the layers of bronchial wall which you'll be seeing. And in this screen, you can see there's a dark patch. I think you can appreciate that. So these will be a dilated bronchi which is seen in the swan line. Yes, sir. Dilated bronchus will be seen inside the lesion. And there are small hyperdense lesions that probably could be vessels there inside. These are calcifications, and some calcifications are also seen. So with this, would you like to say whether it could be malignant? Is there any chance of saying that malignant or benign? So, and mostly it's a homogeneous kind of patterns. So it will be the chance of malignancy there. So we went ahead and then we did a really EBUS guided biopsy. We took almost 6 samples for this patient. Whenever it's narrowing the bronch, then calcification. So as calcification suggests something it's malignancy or benign. We like to take that one experience. It shows only it may be a classification or it may be some other things because what we are seeing is the heterogeneous pattern. Like, some inside is homogeneous, outside we have hypertrophic patterns there. There are some pointers for like to suggest malignancy in a patient with with ready labor. So that actually we have mixed results and all these things certain pointers are there. So we can tell that. But with them, actually that hydroponic spot, it's very difficult to comment. That is. So next the most interesting part. This patient had atypical cells positive. INC suggests P53 was positive and referred as a malignant node. We also have microbiology saying AFP smear positive and gene expert are also positive. So now what next? Same there's another.
Actually, here we have caused some two diseases. So as one was telling, you start spatial and negative because there's a clear cut proof AB positivity is there and it is scored by gene the genetic test also. So that is clear evidence. And start the ABT and after that plan for complete remote because we patient has doesn't have any other nodes in the mediastinal staging. So it's a clear case.
So when will you plan for surgery?
At least 4 weeks. At least 4 weeks.
So what happened next is as you all agreed, we went there and treated the patient with ATP. And we waited for 8 weeks. There was no resolution at all. Then months of waiting, no resolution, and then we waited by. So the bioweapon showed intrafacial nodule, nodule which is involving both cerebral and low. And then this was the HP which was released yesterday. And so this patient had a mucinous adenoma. This is how radial EBUS is actually changing the dynamics from conventional CT to pulmonology based diagnostic routine, the diagnostic tool. So I think it's over for the panel for this. We should for this the tissue unfortunately is then new for themselves. But not very tiny bits. So
What are the note in the AOP culture sample? That bar you said no next usually it's like
not something present.
no the you have sent a bar sample to AOP positive gene X was negative. They do a AOP culture just out of curiosity.
Maybe I should go back and it's only at 40 minutes. Then 40 minutes.
It could have been a dual pathology. The primary lesion could have been the lung malignancy. The additional immune suppression was the additional lesion of the tuberculosis lesion.
So anyways, patient all hearing. Yes, that's right. Yeah, but here the AFB was also positive. Gene export was also different. So as you are complete, we don't want to take the number. Then
The other problem is you have just straight away done the surgery and the patient had a TB, the subsequent treatment, the sealing, everything would have been an issue for you. Not a proceeded the treatment and also. No, it's also that you'll be in the court, you'll be hampering all the colleagues who have done this surgery, the exposure, lot of actions are there for us. What you've taken is the correct step. You waited for adequate enough for clearance of that bacteriological conversion time frame.
so here what so just want to highlight the importance of having a radiation in your bronchoscopy suite and sport. We could do more peripheral nodule management by pulmonologists. This one's clinics and what we are doing.
Unfortunately, we could not get that video to see the complete plan of the list. Like only one third before. So actually, this but size lesion with no nodal analysis, it's very good that it's good for the patient. Like ideally, patient was very big. But what's my worry is that during the surgery, if the surgeon sampled the nodes actually, whatever it is there, because is there any upgradation or upstaging or that? Not so.
The clear in patients.
See, also this is a mucinous mucin positive I
The report was actually they shared the slide and then they only said it's useless. Useless. They're running IX, so they're probably in a couple of days to know what exactly it is.
But
what it is,
like devastating lesion also. So that was the example. When you show us any right?
But that's why it was more about I think the patient is really experimented at the correct solution. We were only to get communities.
The decision on the biologotomy was a non-table decision, non-table
Actually, pre-procedural bronchoscopy and the surgical oncologist felt it to be only in the upper. In spite of radiologist reporting, there was a crossover from the patient. But they thought it was only up. Now, on table, they found it was actually processed and then were both low. But I don't know. I think what a surgeon would have given us a better picture about how segmented we would have built these kind of pictures with a good margin of 2 centimeters. Whether we could have saved the rest of the lungs. We think because there is no It's a module where you go to 2 centimeter diameter, that would be 7,000. Yeah, it's kind of segment that you segment using that. So everything for 900.
Complete the course of APT. And also you go like asking relevant experience.
Like being survey. And whether to because we don't know that where is the process. Maybe like it's better to remove also. It's always better to complete the course of it. Like
Section and the lymphatic flow. I don't think this removing one lesion is doing away with the treatment of TB per se. You have to complete that course.
TB per se.
That has to be completed. We are
Whether they from save the dose, if you go for a limited resection, what the surgeon does, even the member.
actually, this is a very good case actually for doing surgery. As we are package has told, I'm also agreeing that you should not have a considerable surgery for this. Because once you know the balance, I don't want recurrence for this.
That's what even my concern is because it is young, 38 years old. So whether there is a proof of limited restriction where he could have a better or
surgery margins were clear. So whether you need chemotherapy or targeted therapy, I think that should also be.
I think depends on what the ICM treatment patients are there building.
Still the ward, some most of but unlikely to get a patient like this because you are getting a mass which is crossing the fissure. Fissure is the area where the lymphatics actually once it crosses the fissure, definitely lymphatics because are nodes will be there. But it's good for the patient that even during the time of surgery there is no node like
Almost zero. Positive they pick up this is the manager. So just
Sarina Basma, we need to actually do a genetic studies also. Like we need to catch on with the families also. I feel like very young patient, less than 40 years, with not much of risk factors, there will be a hit at the gene level. So I think we have to catch on with that. Yes.
so I think that the function of the organism can diagnose the family.
So much, Karthik sir, for those interesting cases and for that amazing discussion. I request Anupama ma'am to felicitate our presenter and Dr. Kapali sir, please. Question. So much, sir. Yeah. All right, the last round of quiz sessions. Before we jump onto the hands-on session, guys, awake. This is for both the faculties and the students. can see like 10 people there and few of my teachers over there. Raise your hands, all right? Please comment on the graph and select an answer for the graph B. We have a maker. Can you stand up and please audience? You see no, sorry. Option C. B. Option E. E. Vocal cord. Yes, sir. Vocal cord. Yes, okay. That's the right answer. Vocal cord's function is right answer. Okay. Next question. It's again a radiological question, guys. Give us. Now we're going to all the answer again. Yeah, we have what's the answer, right? Yeah. That boy, if he got his hand up, that's the answer. Good job, yeah. It's LCH. You can see numerous cysts of different shapes. Right now we have some cheap difficult questions for the faculty. Chat is already there. Yes. This way around with. Question goes like, in the field of advanced imaging for pulmonary diseases, a novel technique known as hypopolarized gas MRI has been developed. Which of the following best describes the primary advantage of hypopolarized gas MRI in the assessment of lung function? So, Anupam, sir. Sir? D. D or B? B. All right. That's the right answer. And sir, any guess on which gas? But I forgot. All right. It's no, sir. It's helium. Helium. Yeah, it's helium. Congrats, sir. All right. Next faculty question. I think teachers can also take it. You guys are aware of it. So in the field of pulmonary rehab, recent studies have emphasized the role of digital health interventions. Which of the following digital tools has been shown to enhance adherence to pulmonary rehab programs and improve clinical outcomes in patients with COPD? Haven't you already answered your person? Which one? B. Smartphone. Now the right answer. D. No, it's not the right answer. Virtual reality exercise program. So the trial is called VR and VR. Pulmonary rehab in virtual reality. So they'll give you virtual reality classes with which it motivates your COPD patients to start doing rehab. All right. So the last question. In cystic fibrosis patients with severe lung diseases, recent research has explored the use of gene editing technologies. Which of the following approaches is being investigated as potential therapy to correct the underlying CFTR gene mutations in CF? Sir, one, sir. Great job, sir. Awesome. Thank you. You want, sir, you want to tell about it?
No, I don't know.
All right.
I just read the description.
The gene editing, so gene scissors. So last year there was an FDA approved drug for sickle cell anemia and beta thalassemia. It's called, I think it's called Casgevy. All right. So they have been approved by this particular method. For cystic fibrosis, it's still under trials. All right. I think we have one more lucky draw. Yeah, all right, fine. I request our postgraduate Ranjit to pick one lucky draw. Do we have Dr. Sukumari over here? No, all right. So the last question. Targeted therapies for non-small cell lung cancer. A new class of inhibitors has emerged that targets the KRAS G12C mutation. Which of the following drugs represent the most advanced and promising treatment options for this specific mutation? Please raise your hands. Do not speak out loud. I see someone raising his hand. All right. You already answered. You already answered. Good job. All right. Should be. All right. That's it is Sukumar. All right. I will hand over the mic to Jayaraman sir for good thanks, following which we shall have our hands-on workshop. One second. One second. Study on Sunday in such large numbers. I hope you all have at least like 5 to 10 takeaway points from the CME. But at the end of the day, we're all learning, we're all evolving. I hope this was useful to you. Until next time, please join us for the workshop session. With that, we conclude. Thank you so much.